And welcome to the Cato Institute. My name is Michael Cannon. I'm the Director of Health Policy Studies here at Cato. And we're glad that you're joining us this morning for a very important two-panel discussion about the need for health reform. There is, in Congress, we've got a new Congress controlled by the Republican Party. The Republican Party took control of the White House. There is some discussion on both ends of Pennsylvania Avenue about health reform, including the need for health care cuts to balance the budget. But we wanted to have a discussion to encourage policymakers to think even bigger than they are right now, to lay out the case for more meaningful health reforms, why they're necessary, and what some of those reforms might be. So on our first panel this morning, we are going to be hearing from a couple of top experts in the field of health economics and policy about the potential for greater cuts to government health programs than Republicans in Congress and in the White House are talking about right now. And in our second panel, later, we'll take a 15-minute break after this panel and then have a second panel. We'll discuss what some of those reforms might be. So the first panel is going to be talking about the need for meaningful cuts to government health spending. The second panel about how Congress and the administration might go about making those cuts. And I'm very happy. I'll be setting the table at first, but then I'll be turning things over to our first speaker, who is immediately to my right, Robin Hanson, Associate Professor of Economics at George Mason University in Virginia. Robin has the distinction of being my health economics professor in graduate school. Then I'll have some more specific remarks myself, and batting cleanup will be the gentleman all the way to my right on this panel, Mark Miller. Mark Miller is the Executive Vice President for Health Policy at Arnold Ventures. He has also been the Executive Director of the Medicare Payment Advisory Commission. This is the panel that advises Congress on how to run the Medicare program. But he's also held positions at the Congressional Budget Office, the Centers for Medicare and Medicaid Services, which runs those two programs, the Office of Management and Budget, and another think tank here in Washington, D.C., the Urban Institute. So thank you, Robin and Mark, for coming. And just to set the table, I'm going to give just a few basic facts about the federal budget and why Congress needs to be looking at reductions in federal health spending on government subsidies for health care. If you look at these data, these images from the Congressional Budget Office, you'll notice something about both federal deficits and the federal debt. The Congressional Budget Office projects they are going to be growing into the future as a share of GDP to really record levels, at least in terms of the national debt. And this phenomenon is mostly a result of higher than average spending by the federal government, not below average revenues or anything like that. The federal outlays are above the historical trend for the past 40 years by more than revenues are above the historical trend. So this really is a spending problem. And most federal spending, or maybe not most federal spending, but the largest category of federal spending is spending on health care. The federal government spends more on health care than it spends on Social Security, almost twice as much as what it spends on national defense. And that is the part of federal spending that is growing the fastest, growing as a share of GDP. In fact, it's the only category of federal spending outside of interest on the national debt that is growing as a share of GDP. So purely as a budget matter, if you want to get the federal budget to balance, you are going to have to address the rapid growth in federal health spending. what this graph shows is some data from Irene Papanikolaou, a professor at Brown University, and her colleagues, showing that there is plenty of room, giving one indication that there is plenty of room to cut health spending in the United States. You'll often see various versions of these sorts of data showing that in the United States we spend vastly more than other countries do on health care. According to Papanikolaou and her colleagues, about 70% more per person than in these comparable advanced countries on the right. So with that, I'm going to turn things over now to Robin Hanson to talk about some of why it is that the economics literature says that cuts or reductions in health spending are feasible. Robin?
Hello. So we spend 18% of GDP on medicine in the United States, which is much larger than most countries. So the key question about how much we could save is how much value are we getting from this 18%, and in particular on the margin. So as you probably know, there's this huge literature in medicine looking at millions of papers, looking at tens of thousands of treatments. Most of these papers say the particular treatment they study looks like it's useful and beneficial. But there are relatively few studies that look at medicine as a whole and ask about the aggregate value of medicine for health. And most of these studies are going to be looking at some margin, some deviation, like some people get more medicine than others, and asking, are the people who get more medicine healthier? So maybe we're looking at maybe the last half of this 18%. Roughly what's at stake is 9% of GDP. How much are we getting out of that second half of medicine, the 9%? So there are many dozens, even hundreds of papers that take a data set of people who get more or less medicine and their health and try to tease out the effect of more medicine on their health. But as you might know, there are just so many different ways of setting up those studies and so many, honestly, different ways of trying to get the answer you want that it's hard to judge all these hundreds of papers, thousands of papers really, that try to tease out the effect. And the effect often varies quite a lot. There's a lot of these papers that say that the effect on the margin is negative. More medicine produces worse health. Some give uncrazy, huge estimates. But a typical estimate, if there is a benefit, is roughly 1% mortality. And to put that in perspective, that's roughly 2 months of life on average. Out of a 70-year life, that's 1 part in 400 of your lifetime. So what we're really asking is it worth spending 9% of GDP to get 1 part in 400 longer life? So that's roughly the stakes. And so I'm not going to go over all of these thousands of studies. I want to focus on the few studies we most trust. So what we most trust are randomized experiments, where there was a key point where randomly we assigned some people to get more medicine and other people less, and we're looking at aggregate medicine, not just a particular treatment. And then we want to say, with the people who got more medicine, we look at their health after some time period, and we say, are they healthier? That's the kind of thing. So I'm going to go over 4 main experiments that we have that we know about, our best data on this kind of question. The first one was from the late 1970s, 77 to 82 actually, called the Rand Health Insurance Experiment. I first learned about this 15 years after the experiment, when people then were saying, is this kind of out of date because it was 15 years ago? Now it's been another 30 years. But it's still one of our best data points. Basically, the US government spent roughly $50 million at the time to take 7,700 people and over 3 to 5 years either gave them sort of a free pass to as much medicine as they wanted, or they basically had to pay for most of it themselves. They got a small stipend so that we could track it. And then we tracked which group of people was healthier. And the bottom line was that 3 to 5 years of getting free medicine as opposed to basically full price medicine. People with free medicine consumed about 30 to 40% more medicine. They had more visits, they had more dollars spent on their behalf, but there was basically no health difference. Like there were 30 different measures that they used to compare health, and only one of them was statistically significant at a 5% level, which basically means there's no effect. And the closest thing to a strong effect was the people who were sick and suddenly got more medicine, they got worse. But it was a relatively small experiment, so you might say, okay, maybe this effect is smaller than what they could see in this experiment, but that's still quite a few people over quite a few years. So first thing to notice is if you think you know about medical effectiveness because of the story you heard about your aunt or the people you've seen in your life, that can't be right, because if we look at 7,000 people over 5 years and we can't see it in the data, then you're just not seeing it in your personal life. You really have to be looking at the data to judge this overall question. Okay, second experiment I want to talk about is an Oregon health insurance experiment from 2008. So basically, Oregon had some money for Medicaid, but not enough for all the people who were eligible. So they picked 8,700 people out of 35,000 eligible, and for those people, they gave them Medicaid, and the others didn't. So these were relatively poor people. They weren't average people of the population. And basically, for 2 years, they tracked these 8,700 people who got Medicaid treatment compared to the people who didn't get that extra treatment. Now, these people did get more treatment, but in fact, there was no significant effect overall of their health. Now, what there was an effect is that they self-reported their health being higher. They said, I feel better, basically, but they said that before they started getting treatment. So just the fact that they were told they were going to get more treatment made them feel better. And then apparently they were less depressed after that 2 years, and they had less medical debt, which would seem related, but no overall health effect. The third experiment I want to tell you about was called the Karnataka Hospital Insurance Experiment. This was in India, and this was done in 2015 to 2018. And here they took 52,000 people, that's 10 times as many as the RAND experiment, and these were in 423 villages, so these were rural Indians, and they gave randomly, some of them, cheap access to a hospital insurance program. That is, otherwise they'd have to pay full price. Most people weren't paying full price for the hospital insurance, but some people got cheap access to this hospital insurance program. And then those who got the cheap access did, in fact, buy more. So, for example, 78% bought the insurance as opposed to 59% of those who didn't get this extra deal. And it turns out that they used more insurance. So in the first 18 months, the people who were given the cheaper thing, 14% of them basically used it versus 7%, and then over 3.5 years, it was 3% versus 0.5%. So there was a large effect in terms of people giving free insurance, used it more, bought the insurance and then used it. But they looked at apparently 400 different measures that they took estimates for, and only 0.5% of these were statistically significant, meaning that on average there's just no effect. So surprisingly, out of 50,000 people in India, with a substantial effect of half of them getting more insurance and getting more coverage, no effect on their health overall, which is pretty striking. Okay, the last experiment I want to talk about is the US taxpayer experiment, 2019. So in this experiment, what people did is basically they were going to send out a letter to lots of people saying, look, if you don't get insurance, you have a tax penalty. There's going to be a penalty to pay, so you better get your insurance. But 4.5 million people were eligible for this letter, so randomly they took 500,000 people and they didn't send them the letter. And so then they're looking at the people who didn't get the letter, they didn't up their insurance as much, and we're looking at the relative effect on health of the people who got the letter versus didn't get the letter. So we're looking at 500,000 people, 600,000 actually, so that's quite a big thing. And so what they estimated was that over the next 2 years, those people who got the letter versus not got 0.23 months more of insurance. That is a quarter of a month, a week. So basically, the people who got a week more insurance if they got the letter, and then those people, according to the headline estimate, were 0.06% lower mortality. So remember I said 1% mortality is roughly 2 months of life. Here we're talking about 0.06% of mortality because of 1 week of insurance. Now, 1% significance is the headline number, and that sounds good, but if it turns out you look in the appendix and you see, well, they picked a certain age range, so this isn't for the entire population. There's a certain age range, 45 to 65, I think, where they see this effect, and then they try a bunch of other equally plausible age ranges where they don't get remotely the same significant results, like 5, 10, 30% significance, i.e., this is a selection effect of picking this particular age range to see this effect. And if the effect they found was real, getting this cut was basically equivalent to getting a 30% reduction in mortality if you had extended that 1 week over the entire 2 years, which is a huge and implausibly large reduction in mortality. And then the paper actually favors an estimate 13 times larger because they use this thing called instrumental variables, which gets them a crazy huge estimate. So basically, I'd say no effect here. So to review, we have this experiment where we took 500,000 people and we gave them no letter and they got a week's less insurance, and I'd say we didn't see an effect. We have this experiment, we had 50,000 Indians who we gave half of them basically cheaper insurance, and they therefore got more insured and used the insurance more, but no effect on health. Then previously we had the Oregon experiment for Medicaid, where we had roughly 8,000 people, and they had no effect of their health over 2 years. And then the very beginning, we had the Rand health insurance experiment, where we had 7,000 people over 3 to 5 years, and we also saw no results. So I think we're seeing, and we've been seeing, a consistent story here, which is then basically when you look at the worst quality stuff, like just a random medical paper on a particular treatment, you see them saying, oh, this is great, but we know there's huge selection effects in that literature where people will throw away the paper and not publish it if it's not giving the answer they want. Then when you look at aggregate effects of medicine, you see more of a mixed results, and then on the most careful, most celebrated papers, they tend to give more middle results, i.e. maybe not even a significant result, but papers where people are not very careful tend to give positive results about the effect of medicine. So for example, one paper from 2009 by famous economist Finkelstein said that the introduction of Medicare did not actually affect elderly health over the next 10 years from the introduction of Medicare. Well, that's a pretty big overall result. But again, there's all these different things. But the point is, as we get more careful and we hold higher standards to the studies, we get more consistent results that we're not seeing strong effects. And then we look at our most strong data, i.e. randomized experiments, the thing we most trust because there was less room for games and selection, then that's where we see basically no effect. No effect on a margin. So what's the lesson here? So one way to think of the lesson is, if you think about it personally, if you're not going to necessarily be sure whether medicine's effective on the margin, what you should do is cut back. But cut back on what margin? How do you decide, say, which half to cut back on? Well, every study we have that shows questionable low effects on the margin has some way to define a margin. They have some metric by which they define more versus less, and so you can use that as a cue. So personally, you could say, for example, there's something called the Cochrane reviews that review treatments, and some of them it gives high ratings and some it gives low ratings. You could just use that. You could use low spending geographic regions. Apparently places where they spend less on medicine, the quality of medicine there is higher, and you could just only do a treatment for you if they do it there in low spending regions. You could also ask, do they do this thing in a small hospital? Small hospitals do fewer kinds of treatments than big ones. That would be a way to cut back and take less medicine. Or you can even just ask, how strongly does your doctor recommend this, or would I be willing to pay for this out of my pocket? Those are all ways that you could choose a margin and say, I'm going to cut back on this margin because these studies suggest I shouldn't be trusting this. And of course, look, if 9% of GDP is at stake here, we have the potential for huge savings if we could believe that, in fact, the last half of medicine isn't actually that useful. And we could say, well, we're only spending 3% of the economy on the debt, which everybody's worried about, but here's 9% that might not actually be very useful. And so that's the bottom line story here, is to make you realize that, in fact, so there's this key question, why am I the one telling you about this? I'm actually not specializing in health economics that much lately. There's a huge world of people, all sorts of more prestigious people than mine did all these studies, but for some reason they don't highlight the fact that the studies in their literature tend to come to the conclusion that there's very weak effects. Like, even if there is effect, 1% mortality is, again, 2 months of life out of your 70 years, 1 part in 400. And when our best studies seem to show very little effect, i.e., we're not seeing very much in the way of effects from the huge amounts of money we spent on pretty large studies suggesting that we could do without. And my last comment will just be that I actually think, so I gave you a couple ways we could cut back. We could use government to cut back in those ways in its spending, but I actually think there's ways that we could just directly pay for results in medicine by bundling health insurance and life insurance and disability insurance so that individuals could just have a contract with a provider where they had strong incentives to provide you only the care that was cost effective. And that would be not only a great thing to do with your private insurance, but probably even better to do with the government, because the government has a really difficult time deciding which things are quality, because they get lots of people lobbying them to say, you can't cut back on this because that's my income. Anyway, so I'll stop there.
Thank you, Robin. And I'm going to take up where Robin left off and build on his presentation of what the literature says about large variations in health spending and their effects on health outcomes, to argue that what that means is there's plenty of room in government health programs like Medicare and Medicaid for Congress to cut spending. So when I put my list of these randomized controlled trials together, I left off the IRS one, but I included the Ghana one. The story is pretty much the same. You have, over the decade, very few, alarmingly few, randomized controlled trials that measure the effect of increases in aggregate spending on medicine on health outcomes. But the results from what studies exist are remarkably consistent. You can have large variations in health spending across different groups to whom you have randomly assigned people, and not see any differences in their health outcomes. So the Rand health insurance experiment, the Oregon health insurance experiment, you saw increases of 36% in health spending for the people who got the greater healthcare subsidies in those experiments. And in the other studies, you saw smaller increases in health spending, but those are some pretty substantial increases in health spending and no difference in health outcomes. Well, what does that mean for policymakers? What it means is that there's a lot of spending in healthcare generally, and the Medicaid program in particular, for reasons I'll explain in a moment, probably also in the Medicare program, that isn't improving health, that isn't making patients any healthier or any happier with the medical care they're receiving, which means that Congress could cut back on health spending in these programs by a substantial amount without reducing overall health outcomes. In other words, you're not going to hurt people's health in the aggregate if you reduce spending in these programs by a substantial amount. Perhaps by something like a quarter, maybe a third, without reducing overall health outcomes. And this is true of the Medicare program for a number of reasons. One of them is that the Medicare program is a very expensive program. It is not an efficient program. It is even, what this graph shows is that even healthcare spending among the elderly in the United States is even more out of line with international norms than spending on everyone else in the United States. We spend 80% more per elderly person in the United States relative to these reference countries, whereas on average we only spend 70% more. For the average person, we only spend 70% more, but for the elderly we spend 80% more. That suggests that Medicare, whatever it's making the United States health sector more expensive, the Medicare program is even worse on that score, and that there's probably a lot of room for cutting spending in the Medicare program. And consistent with what all these randomized controlled trials tell us, there's a large body of literature from the Dartmouth Atlas on variations in health spending, variations in Medicare spending across counties and across hospital referral regions that shows that in some areas of the country, doctors just spend a lot more, do a lot more for Medicare patients than in other areas of the country, but they cannot find differences in health outcomes that justifies all of that additional spending in those high spending areas. They call this unexplained variation in health spending, and it is substantial. One of the leaders in the Dartmouth Atlas variations literature is a professor named Dr. Elliot Fisher, and he wrote a number of years ago that we may be wasting perhaps 30% of healthcare spending on medical care that does not appear to improve our health. He was beginning with the Medicare program. He was also looking at the rest of the U.S. health sector. That means that Congress can cut Medicare spending substantially without reducing overall health among Medicare enrollees. I proposed in recent submissions to the so-called Department of Government Efficiency, just cutting Medicare spending by 1/3, based on what the literature tells us about the literature from those randomized controlled trials, and the variations literature tell us about how much waste there is in Medicare. Just cut Medicare spending by 1/3. But if you want to do more targeted cuts to Medicare, there are plenty of places to do them. The Medicare Advantage program is the part of Medicare that now enrolls more than half of Medicare enrollees. It is the part where instead of the government writing checks to doctors and hospitals directly, it writes one check or a couple checks on behalf of each patient to an insurance company, and then the insurance company writes the checks to the doctors and the hospitals and the drug companies. And what the Medicare Payment Advisory Commission has found is that every time a Medicare enrollee switches from traditional Medicare to Medicare Advantage, the amount that the federal government spends on that enrollee goes up by about 22%. The reasons for that we can discuss. They are a phenomena called selection and upcoding. They're fascinating. I can give a whole talk on them. I love talking about them. But what it means is that the Medicare Advantage program is increasing spending in the Medicare program, and so that's a target, an area where Congress can cut dramatically. We know, or a couple of indications that spending is going up, or spending is higher in Medicare Advantage than it would be in traditional Medicare, is the fact that so many insurers and insurance plans are entering the Medicare Advantage market. This graph shows that the number of plans available to Medicare enrollees has been increasing dramatically over the past decade or so. That's an indication that the insurers are getting pretty lavish subsidies. Also, this graph shows Medicare Advantage enrollment as a share of total Medicare enrollment. It has been growing. That reflects the fact that the people who enroll in Medicare Advantage recognize that they can get a bigger subsidy from the federal government if they enroll in Medicare Advantage. This is them recognizing that, hey, I can get 22% more if I switch to Medicare Advantage. How does that 22% present itself to them? Well, a lot of these Medicare Advantage plans offer things to enrollees that are not, strictly speaking, health care. Things like food, meals, groceries, general living supports, non-medical transportation. You can even get pet care and hair care covered by your Medicare Advantage plan, because these are efforts by Medicare Advantage insurers to compete for the very low-cost, relatively low-cost Medicare enrollees for whom or on whom the Medicare program is spending more than those people would cost the insurers or would cost traditional Medicare. All in all, the Medicare Payment Advisory Commission finds that Medicare Advantage increases Medicare spending by about $83 billion per year. So you could cut $83 billion from the Medicare Advantage program, and you could without harming overall health. The literature on the quality of care that people receive in Medicare Advantage versus traditional Medicare is mixed. There are some quality advantages, but other areas where traditional Medicare appears to do better. Take Medicare spending on prescription drugs. Just about every attempt to compare Medicare drug prices to drug prices elsewhere shows that Medicare pays substantially more. Here's just one example. The Veterans Health Administration pays about 50% less for prescription drugs than the Medicare program does. So cutting Medicare spending even more dramatically, Medicare prices and spending on prescription drugs even more dramatically than the Inflation Reduction Act does, I think is economically feasible in that it's not going to cause harm to seniors' health. You might argue, as the drug companies do, that if Medicare reduces the prices that it pays for prescription drugs, we'll get less innovation, we'll get less drug innovation. And that is true. But as we've covered in previous Cato events, that's probably not going to be a very big effect. And it is probably the case right now that we are getting inefficiently high levels of drug innovation, where drug manufacturers, because Medicare and other payers pay excessive prices, drug manufacturers are able to capture more value than they are creating, which is not supposed to happen. And that means that we are getting inefficiently or high and excessive levels of drug innovation, and reducing the prices that Medicare pays for drugs could eliminate that inefficient innovation. Medicare also overpays for lots of other items. Medicare has this reputation of being a shrewd price negotiator. It just isn't. The Gunderson Health System in Wisconsin figured out what the all-in price, or the all-in cost of providing a knee replacement is, and they found that it's about $10,500. I think that was back in, I forget the year, 2016. Back in 2016, Medicare was paying more than that, just in terms of hospital fees, never mind the all-in price, in every state in the union, Wisconsin and every other state in the union. And when the resource cost of providing knee replacements to patients in Gunderson fell because they found efficiencies. They drove down the cost of providing knee replacements. It didn't matter. Medicare increased the prices it was paying in every state, except for, I think, Alaska. It went down by a negligible amount. But this is one indication that Medicare is just not that shrewd a price negotiator. In a market system, competition would drive prices toward the marginal cost of providing knee replacements. That is not happening in the Medicare program. Medicare appears to be overpaying. Medicare also overpays for evaluation and management services. It pays hospitals substantially more than physicians will accept for those services in their offices. Congress is trying mightily to reduce those excessive payments to hospitals. It's not working very well. There are other what we call site of service differentials, where Medicare will pay hospitals $2,000 to do a cataract removal that doctors will do in their offices with the same level of quality for just $1,000, but Medicare just keeps on paying and paying. What about the Medicaid program? Well, you often see variants of this argument that if Congress cuts Medicaid, then that is going to limit the ability of states to support family caregivers and result in worse or less care or even no care for Medicaid enrollees. This is a very important point. If Congress cuts Medicaid spending, that is not going to limit the ability of states to support these folks. It is going to say that states, if you want to keep these programs going, you're going to have to raise the taxes and fund these programs yourself with state funds. Every state in the union has the power to levy taxes, collect tax revenue, and keep their Medicaid programs exactly as they are, even after Congress cuts Medicaid spending. Congress could eliminate the federal Medicaid spending, and states could still operate their programs exactly as they are today. But what do charges like this, claims like this, tell us about, or even though everyone knows that, even though everyone knows that states could keep their Medicaid programs humming just as they are if Congress eliminated federal Medicaid grants, everyone assumes, perhaps correctly, that states would not, that they would reduce spending on their Medicaid programs. What does that tell us? Well, it tells us that these programs are not popular, or at least it tells us that that current Medicaid spending levels are not popular if the states that are spending all that money can't convince their voters to pay the taxes to fund all of that spending. That means that voters in those states don't want their Medicaid programs spending at those levels because they're not willing to pay the taxes for them. That means that those programs should not be spending as much money as they are right now. And so this argument is not actually an argument against cutting Medicaid spending. It is an argument for Congress cutting Medicaid spending, because in a democracy, the government should not support unpopular spending programs on healthcare or anything else. Also, another reason not to fear Medicaid cuts is that sometimes when Congress cuts Medicaid, and or sometimes when policymakers reduce Medicaid enrollment, insurance coverage levels don't fall by all that much or even at all. There's a study by George Borjas of a change in Medicaid eligibility for immigrants in the late 1990s. Everyone thought, well, this is going to be terrible. Immigrants who are the uninsurance rate among immigrants is going to rise when Congress throws them out of the Medicaid program. In fact, insurance coverage among immigrants rose rather than fell when Congress eliminated eligibility for this group, because the people who whom Congress excluded from the Medicaid program went out and got jobs with health insurance. And their coverage levels actually increased slightly. And in 2005 to 2007, when the state of Tennessee removed childless adults from the Medicaid rolls, there was a reduction in health insurance coverage, or in government coverage, but a sharp increase in private health insurance coverage that almost completely offset that reduction in government coverage. I will wrap up now by noting that in my recent book, I laid out a lot of options for Congress to cut the Medicare and Medicaid programs, to cut them dramatically. And this graph shows what those cuts would look like relative to the CBO baseline for spending on major health programs. And the most ambitious cuts that we've seen anyone propose in Congress, which I think are the Republican Study Committee cuts to federal health spending. But I think we could go much further, much quicker than the RSC would, and eliminate the primary deficit in just 2 years by making dramatic cuts to federal health programs, and doing so without any negative impact on overall health. But Robin asked, why aren't people talking about what the literature says about cuts to, about dramatic cuts to health spending? Well, here are just a couple graphs that illustrate why. This is a graph of some data put together by Barron Associates about giving to philanthropies that work in health policy. We at the Cato Institute categorize that giving by the ideological views of the recipients of those grants. And what we found is that very close to, or a majority of, the hundreds of millions of dollars that corporations and philanthropies give to health policy outfits to work on healthcare, a majority of that money goes to people who want the government to do more in healthcare, who want the government to intervene with spending programs and the like. And even if some of those folks want the Inflation Reduction Act to reduce Medicare drug prices, they're also giving Medicare the power to set those prices, which the industry then captures through expenditures such as these. These are data from Open Secrets on lobbying by economic sector, congressional lobbying by economic sector, and they show that the health sector of the economy spends more lobbying Congress than any other sector of the economy. It has for more than 20 years. I think it's 26 at this point. And they spend about 6 times what the entire defense industry spends lobbying Congress. The pharmaceutical sector spends about 2.7 times what the defense sector spends lobbying Congress. And so all of the money in healthcare, or almost all of the money in healthcare advocacy, is leaning toward government spending more. It's arguing for government to spend more. And an illustrative example is rural hospitals. You'll often hear that Congress has to do something about the closure of rural hospitals. It's a terrible thing. It's economically damaging. It's harmful to the health of those communities. But God bless the folks at MedPAC. This was after you left MedPAC, right, Mark, when they did the rural hospital study?
We've done rural hospital studies, multiple.
They've done them lots of times. I went ahead and put this in a graph to show the very surprising findings that the industry will never tell you. The reason so many rural hospitals have closed is not because Medicaid is not paying them enough. It's not because Medicare is not paying them enough. That's the story you will hear from the lobbyists who are spending all this money to convince Congress to increase payments to rural hospitals. The reason that rural hospitals are closing is because patients in those areas are choosing other hospitals. They are avoiding their local hospitals, driving farther away to go to a hospital that they prefer. So admissions in those rural hospitals that are closing are going down more dramatically than in other areas, and they're going down because people are choosing, not because they're not getting medical care, but because they're choosing other hospitals that they value more highly. This is exactly what should be happening in the market for rural hospitals. When patients choose other hospitals, those inefficient hospitals that aren't meeting their patients' needs should close, freeing up those resources for other people to use those resources to try to meet consumers' needs in a better way. But that's not the story that Congress hears. The story that Congress hears is Medicare isn't paying enough. That's why these hospitals are failing, and that's why Congress needs to increase Medicare and Medicaid payments to rural hospitals. With that, I will, that's just more spending, more data on lobbying expenditures by the health sector and how it exceeds lobbying expenditures by other sectors of the economy. With that, I will turn things over to Mark, and then we will be taking your questions after his remarks.
Well, I think you've just done my presentation. So what I thought I was asked to do is to try and come in and talk about, specific, what I would characterize as more incremental proposals than certainly like putting, life insurance and medical insurance all together, and talk about some things that we're doing. So let me start there. I would like to return to some of this conversation because at least in the international comparisons, and I don't dispute any of that, and whether it's RCTs or the observational literature, the notion that there are large numbers of services that are provided that aren't particularly necessary or even damaging is not a particular surprise. The $64,000 question is how you get the ones that do and the ones that don't, and particularly when you have two actors, a patient who doesn't know and a provider who has every incentive to do it, like how do you get that balance? But there's some discussion there. But the other piece of it is I always thought that a big difference between us and international countries in the commercial sector is the prices that we pay well above this. And this is, of course, more of a utilization conversation in terms of avoiding services. But that time should not be booked against my 15 minutes. I just wanted to that. So there's a couple of things I want to say before I get started here. I was at those places that Michael said. I'm at Arnold Ventures, which is a philanthropy now, and I just want to say a little bit about like how we enter the environment. So these are philanthropists. They're focused on a multitude of social issues: criminal justice, education, infrastructure, a bunch of issues, including healthcare. And in my discussions with them when we set up this portfolio, the notion was to reduce healthcare spending, which philanthropy actually in some ways may be what you were saying, doesn't spend a lot of time on for obvious reasons because it makes you very unpopular in the environment. But there was a real interest in focusing on reducing the cost of healthcare. And when we say that, what we're referring to is think of the commercial sector where the employer and the employee pay for health care through their premiums, and of course the employee then becomes a patient through deductibles and pays deductibles and co-payments. And then on the public side, it's the taxpayer primarily, or if you're in Medicare, you're obviously paying premiums and deductibles and co-payments. So we sort of think of the end payer and how do you reduce cost for them. The other thing that I would say is that for a whole host of reasons, including some of the stuff that you were running through there at the end about like how much change you can execute in the current political environment. We're very focused on things like rent-seeking behaviors or poorly designed public programs that allow those kinds of behaviors, and that's sort of where we have focused. The one thing I want to leave you with on the philanthropy front is this, is we get a lot of blowback from the various industries, and we look broadly at healthcare, the insurers, the providers, the drug, the drug environment, and regularly get blowback. And one point that I would make about that is that the thing that I think distinguishes us from, say, the AHA coming to somebody's office and making arguments about, policy is
The American Hospital Association.
I'm sorry, the American Hospital Association, or any of the major lobbies out there, is they're entering that conversation to protect or enhance their financial situation. We are not. We're expending money. The philanthropists have taken the giving pledge. They're going to give their money away during their lifetime. There's no policy recommendation. You can disagree with them, but none of them are motivated by protecting revenues or anything like that. Anyway, I had a couple of things. We have a long list of savings proposals, both in the commercial Medicare and Medicaid, and given 15 minutes, I was going to highlight a few of them. Michael has already kind of entered that space. But let me just go through and do my thing. So MA, the overpayments in MA. And just to back up, I'm going to assume everybody kind of understands here that as a beneficiary, you can enter the fee-for-service, you can enter traditional fee-for-service Medicare. You go out into the private market, most hospitals, physicians, et cetera, participate in Medicare. You get your service and the government cuts a check. You pay your deductibles and co-payments. Or you go to a private plan like a United, Aetna, Kaiser, that type of thing. And the government, you're required to provide the Medicare benefit and potentially more, we'll talk about that momentarily, provide the benefit. But what the trade-off is you're usually accepting a more narrow network and accepting a world in which there may be different prior authorization rules about how you get your services. But the fundamental argument that the managed care industry, being an old guy, was making back in the 80s to enter the Medicare program was this. I mean, they have higher overhead, 10, 12%. They have they have a profit margin to cover, I don't want to call it 5 or 6, but then they would argue that they could reduce, because fee-for-service was so poorly organized and redundant and all the rest of it, they could produce savings and deliver additional benefits to the beneficiary using the savings. And that was kind of the premise, or to put it differently, to use the money that they get and the savings that they make in order to deliver the benefits, which generally are lower cost sharing, certain services that are not covered by Medicare, vision, that type of thing, but also, a catastrophic cap, that type of thing. Now, there was a long period in which the payment system just ratcheted up over time, and Medicare and we could go through this, it's somewhat complex, but Medicare basically got to the point that Michael was making, which is just uniformly, any person who went into managed care was paid more than fee-for-service. And there was an attempt in 2010 to adjust some of those payment systems, and they had some effect, lowering benchmarks and lowering what was being paid. But they did not completely solve the problem, and the industry started moving in two different directions. One was they realized they could increase their payments through their quality bonus program, which I'm not going to address in detail given time, except to say I think that there is ways to reform that and make it budget neutral, which would remove something like $120, $150 billion over 10 years. But I'm just going to set that aside. The second thing that they started doing was upcoding their patients with higher risk scores, because that increased your payment pretty substantially. Now, this behavior was anticipated, and at MedPAC at the time we were arguing because other prospective payment systems had observed this phenomenon. We were saying you need an adjustment factor to anticipate this and pull it back from the payments. Of course, there's a lot of back and forth, and the industry was arguing it won't happen, have a low factor. We were arguing it would happen, have a higher factor, that type of thing. That factor is 5.9% in law. So one recommendation right now that we would make is that you could increase that factor to match what the current overcoding rates are. And so if you look at estimates from GAO, MedPAC, CBO, various academics, they're and they use different methodologies in most instances. They coalesce around $40 to $50 billion annual in upcoding. There's also a selection effect that was briefly mentioned by Michael, also in there, but I'm just going to leave that aside given time. And so we would say you should adjust the factor up in order to capture this recoding back for the taxpayer, but also keep in mind the beneficiary pays a lower premium, all else equal, if you lower that spending. So you're benefiting both the patient and the taxpayer. Depending on what that factor is and how aggressively you want to go at it, $500, $600 billion over 10 years. CBO came out with an estimate that had an even higher factor. I'm not sure whether they think the coding is higher or whether they're also trying to capture some of the favorable selection the plans have. But their estimate, or their proposal would capture something closer to $1 trillion over 10 years. And so that's one thing that, without implicating large discussions about benefit structure and all of that, where we think that an efficiency could be gained. Okay, the next thing I was going to mention, and this was briefly mentioned in Michael's comments, is referred to as site neutral. And I want to just say out here, there's also a commercial sector version of this. And the term of art that may have come across is facility fees. And if anybody wants to get into that into discussion, we'll return. I'm happy to return to it. But in Medicare, the term of art is site neutral. And the textbook play here is this. I'm a large hospital system. I buy a physician office that's off campus and can be distant from the hospital. So it's not in the hospital. It's not even on the hospital campus. And, this is the same physicians, patients, and services. There is some additional regulatory burden that the office has to go through, but it is, I would argue, not significant, and certainly not significant given what they're extracting from it. And what you do is you simply shift the service from the physician fee schedule to the hospital fee schedule, which through historical accident is a much higher fee schedule for the same service. And so you can literally get overnight, once you convert, this physician office to be part of the hospital, increase your revenues 50, 100, 200%. And that's not exaggeration for a given service, that is. And I also just want to point out that means the beneficiary's premiums also go up, and point out that the beneficiary's copayment, which is tied to that payment rate, also goes up. So the taxpayer is taking a hit, and the beneficiary is taking a hit as well. Now, what could you do here? And these issues have come into play, and there have been discussions around these things. For simplicity's sake, and there is a lot of complexity here, but for simplicity's sake, what you could do is for off-campus, you can say you can't go above the fee schedule. And say that, buy any physician office that you want, but you can't elevate and start billing through the hospital fee schedule. A second idea, and this came out of MedPAC some years back, which was to identify services, and they've identified 57 services. Just for those of you who are deeper, they also identified some ambulatory surgery services. For simplicity, I'm just setting that to the side. But it's the same story, basically. And you have identified 57 services that are routinely and safely done in the physician's office. And then you say these services don't warrant being paid the 50, 100, 200% higher rate, even in the hospital, and say that Medicare as a purchaser will say, this is the price we pay for this service because this is a fair price. If you do that, So in the first instance, if you do the off-campus only, it's about $40 billion over 10 years. If you go and say there's a set of services inside the hospital where the payments should come down, it's closer to $150 billion over 10 years. And once again, I just want to reinforce, for people who care about the beneficiary and or the politics of this, this also helps the elderly and disabled beneficiary. I do want to say just in passing, and we could potentially come back to this if you want to, obviously on the MA side, the industry has very strong objections. We could talk through those objections. And obviously in this instance, the hospitals have very strong objections, and we can talk about those objections. Some of it gets into the rural hospital issue if we end up having time there. The last couple of things I'm going to mention around Medicaid, and again, we have longer lists, but I'm just trying to highlight a few things. And in Medicaid, there is a situation where, so we're going to do a technical graph here. So if you're on fee-for-service in Medicare and Medicaid, the state is allowed to pay the rates that it wants to pay, except that Medicare is a limiting rate. But then over on the managed care side, and a lot of the program is moving in the managed care direction, you're allowed to pay above the Medicare rate. Now, some of the thought process was, well, you might be involved in incenting people to do better quality, save money, whatever the case may be, and on a case-by-case basis, you might actually be paying somebody above the Medicare rate because you're rewarding them. But that has turned into a situation where, say, a powerful interest, hospitals, nursing homes, whatever the case, may approach the state and say, I want a lot more than Medicare. I want commercial rates, which in the hospital sector, because of consolidation in the commercial sector, 400% of Medicare. Now, this was out there, and then a late regulation in the Biden administration said you're allowed to go up to commercial rates, and we think that this is not a good direction to go in. So there's that, and so the policy change there would be to limit, like on the fee-for-service side, how high above Medicare you could go. You might leave a little room in order to allow some incentive structure, but not 200, 300, 400%. But this is usually coupled with a second idea, which is this. So say the hospitals approach the state and they say, I want a lot more money. And the state says, and Michael also spoke to this, like the state says, well, I don't have the money to put up for the match. And let's just pretend it's a 50-50 match, so I have to put up $50 to get $50 as the state. And so what the state says to the hospital is, you pay me that, and I will put it up for a match, and then using the Medicaid contract, I'll give you back your tax, and I'll give you the additional payment amounts that you're asking for. And so the policy change on this side is that this recycling of the tax is allowed up to a certain percentage, 6%, of the entity's revenue. You could push that percentage down. And for example, if you go from 6% to 5%, it's $50 billion over 10 years. And on the other side of the ledger, if you limit how much you can pay out on the managed care contracts, it's in the $100 to $120 billion range over 10 years. Now I'm going to stop, except to say this last couple of things. We're talking about the budget, and that tends to draw your attention to things like Medicare and Medicaid and those types of things. But remember also that the federal government subsidizes employer-provided insurance in the commercial sector. And so if the government were to act in any way to limit costs in the commercial sector, then that actually comes back through to the budget in additional revenue. In other words, it's less subsidy that goes out the door, so all else equal, they have more revenue, and again, all else equal, the deficit would be lower. So for example, if that facility fee idea that I mentioned a minute ago, the site neutral or the commercial version of the site neutral were somehow limited, that would also help businesses and their employees who are paying premiums, but it would also have an effect on the revenues that are available in the federal government. So I think with that, I'll stop, and I don't know how much time I took.
I think we've got a half an hour for questions from each other, for each other, from the audience. I want to remind everybody that we're going to be wrapping up at 10:30 Eastern Time, then take a 15-minute break, and we're going to have our second panel at 10:45 to health reforms that meet the need. We're going to be discussing how to take the insights from this panel and translate them into policy so that we can get better health care and also put the federal government on a more sound fiscal footing. We've gotten a lot of questions from our online audience so far, and some really good ones. I'll start with one for Robin. It says for all speakers, but this is really, I think, a Robin question. How are you defining outcomes today? More specifically, in the context of this conversation, how do you take into account quality of life?
Right. So most studies in the larger literature that isn't randomized experiments looks at mortality, i.e. whether you live or die. And in fact, over time, people living longer has been, in fact, the major benefit of health. That is, people have also gotten healthier, but the major thing that's happened over time is that people have lived longer, and so it does make sense to look at mortality. And when we can look at mortality, again, we see small effects, maybe zero, maybe even negative effects in the usual sort of statistical studies. In the randomized experiments I'm looking at, they tend to be small enough over a short enough period that it's hard to actually look at deaths because not that many people die in this period, so they look at other health measures. So I mentioned that in the RAND experiments, they looked at 30 different health measures, including some overall health measures, and there's just no overall effect. In the India hospital insurance experiment, they basically apparently looked at 400 different things they were estimating different in the groups, different health measures, and again, only 3 out of the 400 measures were actually statistically significant, which is what you'd expect by chance. So in the experiments that are too small over too short a time for death to be something you can track, then we have lots of ways to measure health, including just asking them how healthy do you feel and often functioning, i.e. can you do your usual things in life? So a key metric of health is, can you get to the store? Can you get up without, by yourself? Things like that. Those are some of the key metrics that we use in health policy. And for those metrics, again, in the experiments, no overall effect.
Next question is from our friend at the American Enterprise Institute, Joe Antos. Can you please post links to the studies cited by Robin Hanson? We will do that for you, Joe. We'll get on that. I'll put it on a blog post or something. Next question, how and where does Congress I think this is a question for me, how and where does Congress just cut Medicaid spending by 1/3? What does that look like for the average 70-year-old? I have a lot to say about that, but the answer is one that'll come up, I think, in David Hyman's presentation in the next panel when he talks about Medicare reforms, because the way he talks about them, has proposed reforming Medicare is very similar to what I have in mind, what I write about in my book and in that proposal. I also want to let our in-person audience know that we're happy to take your questions as well. Please raise your hand, wait for the mic to come to you, state your affiliation, any relevant affiliation, and make sure that you are asking a question, not providing a speech or just a comment. Did we have a question on this side? No, okay, not yet. All right, we have plenty here from online. From Anonymous, perhaps the problem is a lack of spending on what does improve health: fair housing, childcare, good schools, fair wages for parents so they're not time constrained and stressed. Please address this possibility, which I would consider almost a certainty. I do think that is part of the reason why the United States does have obviously better health outcomes, or maybe even apparently worse health outcomes than other countries, is that there's so much compulsion from federal and state governments that requires us to spend money on medical care that doesn't improve our health, that we have less money left over for things that do improve health, like housing, like education, nutrition, and so forth. And there is this movement now within health policy circles to focus on what we call the social determinants of health, which is really just a way of saying the government has forced us to spend so much money on healthcare that we're now not as healthy as we could be because we're not spending money on these other things. Let's try to shoehorn those things into the definition of healthcare so that the government will subsidize them as well. I would argue that a better approach is to make these sorts of dramatic cuts in health spending, government health spending that we're talking about, because that will leave more resources in the private sector so that people can choose whether they're going to spend that money on medicine or they're going to spend that money on housing or education or what have you. Robin, Mark, anything to add?
I'd like to emphasize that in the social determinants of health literature, we see many things that correlate with health quite consistently. So I've told you that when we look at correlations of medicine and health, we just find it hard to see very consistent effects and very large ones. But for large numbers of other correlates of health, they are quite consistent and large. The literature does not find it hard to see the effects of air pollution, sleep, nutrition, exercise, smoking, a wide range of other things. So that's to say it's not that statistics is just impossible to see things, it's that medicine is a really weak effect compared to all these other effects that we can see are large and consistent effects.
Yeah, and I'm not deep enough on the public health and social service side, child care side, but have, just as an observer, have felt like the balance between how much we spend on medical versus that does seem completely out of sync, and that you could get better effects. And then also, as I'm trying to point out, even beyond the interaction in the room between the patient and the caregiver, is the notion of the institutions around them and what they're doing to extract revenue out of it, which truly doesn't have anything to do with the actual delivery of care, like just generating extra revenue because you bought a physician's office. Anyway, back to you.
Next two questions are very similar, from Lawrence Hurwitz, MD, and Eric Tubbs, online viewers, who very bravely used their names. Most questions are from anonymous, so thank you for doing that. And Dr. Hurwitz asked, what would a true free market in medicine look like, particularly for doctors? Mr. Tubbs asks, has Cato assembled a comprehensive free market-oriented plan to improve health care and drive costs down? I'm so glad you asked these questions. I do that in my most recent book. We have published other books for the Cato Institute from our scholars, David Hyman and others, that lay out this case. I would refer you to the book part of our website. My book is Recovery, David's is Overcharged, and there are other resources there that lay out those ideas even further. And thank you for your questions. I've got a question a couple questions actually for Mark. This is something that Robin and I were talking about in the green room before the show, the event. The literature on the effect of changes or variation in health spending on health outcomes, the randomized controlled trials that Robin and I have been talking about, they don't seem to get a lot of attention in health policy discussions. Whenever people propose cutting spending, there's no reference to this literature, except from maybe people like Robin and me. And certainly no one on Capitol Hill is talking about these things, but also not really all that much attention in academia and broader health policy circles. We were offering theories for that. I was wondering if you had any thoughts on the validity of the literature and why it doesn't get more play in health policy discussions.
Oh, well, I think I started to, first of all, I think it does get attention, depending on what we're talking about here, if I'm following the question. But, the notion of the RCT results or the observational literature identifying, large percentages of medical services that don't seem to have any effect, that doesn't come as any surprise. And I think if you're close to this at all, none of that should surprise you. I think where the question becomes complicated is, and I started to implicate this when before I started my own comments, which is how do you actually get the services that do in fact have an effect and avoid the services that in fact don't have an effect. And I think that there has been a lot of work devoted to this. So think about things like, whatever the success of them, but think about things like an accountable care organization where you're trying to say to the provider, there are outcome measures that we're going to look at here, so provide care accordingly. There are ways that people try and eliminate first dollar coverage, that type of thing, in order to get people to think about the consumption of services. Of course, I think what the literature says there, I'm pretty sure it says, but good and bad services get kind of pulled in that instance. So I think and then you have things like, trying to shop for services, but I think some of the issue there is how much of those or how many of those services and how much of the revenue or the spending here that we're talking about can actually be captured by stuff that somebody, that a patient could say, all right, well, I'm going to choose my way around these things. So I think there has been a lot of attention to trying to, extract more effective utilization in order to try and overcome some of the issues that people are seeing here. But I don't know that they have been highly effective. The other thing I would say is, 80s, 90s, there were a lot of the spending was driven by utilization, but utilization rates also slowed down, which doesn't mean that the utilization actually occurring still is it does mean that the utilization that's still occurring is problematic. But at least in the commercial sector, I think the problem has shifted much more to being a price problem than a utilization problem. But I do think there's attention to it. I just don't know how successful any of it's been.
Brian Blase.
Is it on? Yes. Question for my former professor too, Robin Hanson. So I think today you made a very effective case that a lot of medicine doesn't provide us with better health. I know you've also done significant work into the why we spend so much on medicine that doesn't do things for our health. So I'd like you to explain that, and then how the answer to that can help inform our efforts to collectively reduce ineffective and wasteful healthcare spending.
Thanks for that invitation, which I'm happy to take. So I think you'll all notice a discomfort in yourself when I tell you these results that maybe half of medicine isn't helping health, because that's going against something very sacred in our society. The idea, United States kind of tells itself that the world should be grateful for having invented modern medicine. And we gave this great gift to the world of modern medicine, and it's such a great thing. They should all be so thankful. And we drive most medical innovation in the world by spending so much more than everybody else. And we're kind of okay with that because we're proud. We're really proud to be the source of modern medicine that we really revere, and that's why we spend vastly more than the rest of the world per person on medicine. So to hear that it doesn't actually work is pretty devastating to a sacred part of our, national mystique. And that's why people are sort of reluctant to say, well, we need another study, this can't possibly be right. They try to look at also so many different ways. And I think you have to realize just how central to a lot of our self-concept as a nation and individuals, this idea of, most families have a story about how grandpa or whatever was saved by medicine and he would have died had not, various treatments happened. And that's sort of central to our mythology of our society, and modern people who are like STEM, science, yay science. Often it's about, well, science is great because medicine is great, and medicine is great because science lets medicine be great. And we really centrally have that. So that's the thing I want you to sort of realize that you might not be willing to listen to. So there's an essay out in the lobby that I had out there called Cut Medicine in Half. But in the discussion for that, I gave this anecdote of the monkey trap. So there's this perhaps apocryphal story that in many places around the world, the way they hunt monkeys to eat would be to put a gourd, a big bowl, and they put a nut inside, and the monkey reaches his hands inside and gets his hand around the nut, and then the entrance is too small to get his hand out again. And he won't let go of the nut because he really wants that nut, and then you can catch him because he can't run very fast because he's got this huge thing on his hand. So that's kind of what we're doing with medicine. So whenever we talk about, okay, people say, sure, fine, lots of medicine is useless, but there's an old ad industry thing, which is, yeah, half of all ads are useless, but we don't know which, so you have to pay for all the ads. And that's kind of a story people give about medicine too. Well, we couldn't really trust any particular study to really say you should cut this because, well, it might be wrong, and we really don't want to give up any medicine that might maybe be useful. And that's the monkey trap of not being willing to cut. I'd say, look, we have a bunch of margins on which, on the aggregate, they're not giving a net benefit. I'm willing to just cut those things wholesale. Yes, some of them might be good, but they're packaged with other things that are bad. Don't be trapped as a monkey in the monkey trap of not being willing to let go of anything. Consider that maybe this whole medicine thing is just worth much less than we've said. And look, we spend $2.5 trillion a year in the US on the second half of medicine. So that's what's at stake. They've been talking about cut maybe 50 billion, cut 100 billion, but we could potentially cut $2.5 trillion a year without substantial health costs. That's the big grand idea when we're thinking about think bigger here in medical reform. I would say, think about the idea that the entire thing might not be worth nearly as much as you think.
I just wanted to follow up on that question, though. Can you give more tangible examples, though? Because I think we all, if we were to accept that argument, then what are the things we need to let go of versus the things that truly do bring value?
Well, so that's what I was ending with in my discussion, but I'll repeat. Every study that looks at the effect of the marginal medicine has a way in that study that they identify the marginal medicine. So all of those methods could be used for us to cut back on medicine. So for example, sometimes we see basically large hospitals do more kinds of treatment than small hospitals, and they don't seem to be beneficial. So cut those. Whatever the large hospitals do, the small hospitals don't. Regions that spend more, they do some kinds of treatment more that regions who spend less don't do, cut those. We can also see that when we change the price, people drop some things. So even personally, you can ask, would I be willing to pay for this out of my own pocket? If you wouldn't, maybe just don't even get it, even if somebody else is paying for it, because that's another one of these margins where we see, on average, that stuff doesn't help. In addition, there are these standard ways to evaluate treatments. The Cochrane reports is one, very well respected. They rate lots of treatments. You could just take the low half rated treatments and don't do them. So we actually have lots of ways that we rate and evaluate medical treatments, or that we see margins. The reluctance is you take one of the things in the low half and people say, well, how sure are you that, maybe some of that's good. Do you really want to throw the baby out with the bathwater as the story? Yes, let's throw the baby out with the bathwater, I'd say. The baby isn't really that great.
The baby is great. The bathwater is not. If I may,
Can we stay there just a second?
Go ahead, Mark.
Particularly with the baby thing. I think, I understand. First of all, and now the number's gotten to 50%, and I was thinking that at least in the observational literature, it's more in the 20 to 30% range. But I think the difficulty in this is a couple of things. I think you can find examples where there are populations who suffer from some kind of disease or condition that in the past would have been life-limiting and no longer do. And so people do attach them. You may call that the monkey thing. But there are actual innovations that have occurred. I think the second thing that makes it very difficult is case by case, you don't know what service helps that person versus another person. And there are lots of services, I absolutely agree, the Cochrane type stuff of nobody should be doing any of this to anybody. And so, for example, Medicare coverage policy should probably, or Medicaid, whatever the case may be, say these are not useful services, and they should not be covered. But of course, there's huge resistance to those types of things. And then that moves you into a place where you try and incent the provider to be aware of what's going on in the literature and say, this, I know everybody's talking about this, but this isn't going to help you. Because often the patient doesn't understand what would or wouldn't help. And so I think it's very hard to get to these points, and certainly a 50% point, because there are examples of innovation, and there are examples, or there is the situation of case by case. It's very hard to judge whether this service might help you, but it wouldn't help me, for example. So I do, to your question, I do think that this stuff gets pretty complicated to really execute on the field. Now, I think where you two would go is say, well, just give people money and let them decide. And, you know, there are probably discussions that need to occur around something like that.
So I think what the question you ask is a really complex one, because medical care is this incomprehensibly vast array of goods and services. We're talking encounters with clinicians at different levels of acuity, and whether you bump someone up to a higher level. We're talking about all the tests that they might run on you. We're talking about all the drugs they might give you, all the things they might do to your body on a surgical table. I mean, there's whether they'll admit you to a facility, what kind, and then what they'll do to you once you're there. It's so complex that it's very hard to say, oh, well, this stuff right here is the wasteful stuff, and we'll just get rid of it. It's actually stuff within each of those episodes of care that are unnecessary, and sometimes entire episodes of care. And so what is, you know, it could be that the same pill that was tremendously beneficial for me is not for you, or the same surgery that was tremendously beneficial for me is not for you. But if the government is subsidizing us both, you're going to get it as well. And so how do we find out, you know, what that item is and which one of us is going to benefit and who isn't? It's really hard to know. But I think what Robin is trying to say, and what the RAND health insurance experiment illustrates really well, is that you can have different mechanisms for deciding between what is the wasteful stuff and what is the beneficial stuff. And most of them will do a pretty good job, or at least that's what the evidence tells us. Because the RAND health insurance experiment was great because it had multiple arms. It had one arm where people had basically a high deductible health insurance plan. They had to pay the first few $1,000s out of pocket, and then insurance took over. But then it had other arms where people paid 50%, 25% of cost sharing up to the deductible, and then insurance took over. And then it had some people where basically they had free first dollar health insurance, so they paid almost nothing for their medical care. But it also had an HMO arm. So what's great about this is you got to compare the people with the high deductible plan to the people with the quote unquote free care. And what the researchers found was that once they went to the doctor, the people who had the high deductible plan and the people who had the free care, they got all the same stuff. The difference was that the people who had a high deductible didn't go to the doctor as often. So they didn't go to the doctor. If they went, they got all the same stuff, you know, controlling for whatever factors they could control for age and sex and diagnosis and that sort of thing. They got all the same stuff, but making them price sensitive at the point of going to the doctor, whether to see a doctor in the first place, led a lot more of them not to go to see the doctor, enough that their overall spending was 30% lower because then they didn't get all of the stuff, and that didn't harm their health. So that's a pretty crude rationing mechanism. I'm just not going to go to the doctor, and so I'm not going to get all that stuff. And that crude mechanism did not result in worse health for those people. That's fascinating, by the way, but that's one way to do it. The HMO arm provides another way, which is, I think it was Kaiser was the HMO that they used, and they randomly assigned some people to get a Kaiser health plan. Kaiser operates differently from all the other doctors and hospitals in the RAND health insurance experiment in the United States generally. They don't have an incentive to do more stuff like you do in a fee-for-service system. Because all the doctor, Kaiser owns the hospitals and employs the doctors and doesn't pay them more for doing more, and because they're basically the insurer, they have the opposite incentive, whereas fee-for-service encourages doctors to do more. Prepayment or global payments or capitation encourages the Kaiser system to do less. It encourages them to find what is all that wasteful stuff that's not really helping people, or how can we help people at a lower level of acuity. And whatever Kaiser was doing to reduce spending, and I forget what the spending differential was between them and the other arms, but they had less spending than the free care arm, and whatever they were doing also didn't harm overall health. However they cut did not harm overall health. So there's really, there could be, in addition to the strategies that Robin mentioned, there could be a multiplicity of strategies where you're making people price sensitive, or you're transferring the price sensitive, the cost consciousness to the plan, and letting them weed out what they think is the wasteful stuff, and none of it harms health. So it really doesn't matter what mechanism Congress uses. This is why I wanted to have this panel to begin with. What the literature suggests is it doesn't matter how much you cut, just cut like crazy. Cut Medicare by a third, and it's not going to, what the best evidence we have suggests is it's not going to harm overall health. That provides Congress, I think, a wide latitude to reduce healthcare spending from current levels.
This is not unprecedented. So the actual historical causal effect of the RAND health insurance experiment was it induced a lot of corporate leaders to push their employees into HMOs. The RAND experiment said, look, HMOs are cheaper and they're just as healthy, so let's push people in HMOs. So in the late 80s, early 90s, there was a big movement of corporations to push their employees into HMOs that only ended with the sort of revolt of the public. Say there was a movie called As Good as It Gets, where they really said, well, the HMOs are terrible because they're taking away this needed treatment, and the public revolted, and then that stopped the HMO revolution. But basically, corporate leaders saw the results of the RAND experiment, believed it, and on that basis were willing to cut back medical expenses for their employees. So this is really fundamentally about public opinion about medicine. And so that's, I think, the more fundamental constraint here is that most ordinary people feel like they just need to have as much medicine as whatever their doctor recommends, and they don't want to trust any other source on that claim. And that's basically our problem here, is to get the public to maybe question enough that they'd be willing to accept at least some forms of cuts.
And part of the reason that I'm focused on what I'm focused on and went through here is that, I would argue that the things that I'm pointing to don't implicate these issues. The public's reaction that you just took 1/3 of my benefit away. I'm focused very much on kind of revenue generation, rent-seeking types of behavior, where the person in question is, a large hospital system, the managed care plan, the state, playing, some recycling game, that type of thing. And so I think, you can dismiss it as 100, a billion, 500 billion, whatever your point, is. These are at least being discussed, even in the current environment. So, I would just kind of point that out. And the thing I would say on the commercial side, which I don't think we've touched on a lot. Again, a lot of this is about affecting utilization. On the commercial side, we have a massive amount of consolidation that has occurred, and we're paying 300-400% of what we pay in Medicare. And you can argue whether the Medicare rates are wrong, but they aren't wrong by 400%. I'm willing to take that position. And, one could raise questions there without even removing a single service and saying, why the hell are you paying this much for a service, which is sort of the way I am thinking about things.
I have a question for Mark related to that, but this woman over here has been waiting very patiently for the microphone, so, okay.
Hi there. I guess I don't need to stand up. My name's Anna McAllister. I've done a bunch of different stuff. I used to work here in a previous life, but since then I've done a couple of health tech startups. I do a lot of, I'm personally currently working as an independent consultant focused on mostly health data issues, but I've done a lot of personal advocacy from the perspective of a patient with complex type 1 diabetes. around quality measures, reform, and how to make things better. So I was super intrigued to come back to Cato after a million years and sort of see where things are. And I'm incredibly frustrated. My head's about to explode. I have so many counterpoints to many of the arguments that have been made, but I'm not here to make a speech.
We're asking for a question.
Yes. So one of the questions and the frustrations that I have is that so much of the incentive is about, the incentive structure is focused, I don't know, it's like we try to take these blunt instruments and apply them across the board. I mean, you're saying just cut 1/3 and things will get figured out. Well, there are going to be consequences to that. So one of the things that actually has worked from the perspective that I've seen as a patient is some of the quality measure reforms that have been placed on physicians. And one of the arguments that I've made over the years is why aren't these same quality measures being applied to insurance companies or pharmaceutical companies? There are ways that we could take a far more nuanced approach to medication prescriptions that are not being taken because the pharma companies know that if you give medications to a whole bunch of people, they're going to make a whole bunch of money. But if you do pharmacogenomics.
Is your question that quality measures help reduce spending?
Well, if you apply the same kind of quality measures to the people, to the cost centers, such as pharmaceutical companies or device companies or insurance companies, you might be able to start changing the incentive structure by making them be better and be more precise in what they're selling.
Okay, how feasible is that? How might policymakers or payers go about that?
I'd say that it is quite possible to have much stronger incentives on medical providers, and that's been suggested for many decades by health economists. And policymakers have often nodded in that direction and done some small things in that direction. There are some small quality metric payments for many of these organizations, but
pharma companies and device companies and insurance companies.
But the fundamental fact is that most ordinary citizens trust their doctor as their primary advice on medicine. And when they hear some other organization pressuring incentives on their doctor, they think, no, that's not right. This doctor needs to be free to give me the advice he really believes in, and that's what I'm going to trust. So I think fundamentally it's the public opinion being reluctant to allow stronger incentives that would constrain, in their mind, their doctors. That is, so other areas of the economy, we trust providers much less, and we're much more willing to have stronger incentives about auto repair people or home contractors and all sorts of other things. Medicine's quite unusual in the degree of sort of emotional attachment and trust that people just want to put in, not in the whole system, but the person in the system who represents it to them, which is their personal doctor. And that's, I think, a major obstacle to changing the system and changing incentives, including the sort of incentives you're suggesting.
Mark?
Yeah, I'm having a hard time, sort of formulating a response here. So, I mean, there are things for drug companies. I mean, they're supposed to show safety and effectiveness. We could have really long conversation about how effective the FDA is on that front. When you speak of, you said insurance companies, at least in the Medicare program, and I think this has been a failure, just to be clear, and largely because how it's approached. There were requirements for quality, there are requirements for quality outcomes. I think the measurement, the state of measurement in that is so highly flawed. I don't have a lot of faith in any of the stuff that's coming out of that. But if I follow your point, which I'm not, as best as I can, I mean, there are statements of like putting quality, requirements on the managed care plans, for example, the insurers who are serving Medicare beneficiaries. I think it has largely been a failure, but that could also be the particular design of how it was done. The other thing I'm going to say is that, the quality measurement process became kind of an industry in and of itself. And there's just tons of burden and tons of reporting, and so little of it is really even, I don't even know what it's measuring, much less affecting outcomes. And we could have a longer conversation that when you say impose something like that, what is the regime and how much weight or burden does it put on, the system, which may be justified, but Also, I feel like physicians, for example, which you took out of the equation, have just been overburdened with the quality stuff, and I don't think it has any effect, has had much effect. But I'm not sure. I'd have to think more about what you're asking.
Thank you for your question. Thank you, Mark. And thank you all for coming. I have more questions. There are more questions from online. We're not going to be able to get to all of them because we're a minute over time already. Steve Moses, I can tell you, I think we'll cover your question in the next panel, so I hope you stick around for that one. I want to thank Robin and Mark for their comments. And I want to ask you all to, after this 15-minute break, join us again for our second panel. It will begin at 10:45 Eastern Time. And then those of us who are here in person at 12:15, when that panel concludes, you can join us for a luncheon. Thank you. Welcome back. Enduring me for an hour has earned you another hour of the same, but to soften the blow, to give you a spoonful of sugar with that, I've got my next two panelists, my far-right Cato adjunct scholar and professor of law at Georgetown University Law Center, David Hyman, and immediately to my right, Paragon Institute President Brian Blase. We're going to be talking about some of the reforms that Congress is not discussing, that go farther than the reforms that Congress is currently discussing when it comes to health care, in the areas of private health insurance as well as government programs like Medicare and Medicaid. Without any further introduction or ado, I'm going to go ahead and jump into what I argue is the most important thing that Congress needs to do in healthcare, which is to correct what I think is the original sin of U.S. health policy, which is the creation of the income tax and the tax exclusion for employer-sponsored health insurance. I'm going to give you some reasons why I think this is the worst part of the worst thing that Congress does in healthcare. It creates all of the problems that the Medicare and the Medicaid program are trying to solve, all the problems that Obamacare tried to solve, all the problems that Congress has been trying to solve in healthcare for the last 100 years, and why reforming it in the right way is not only politically feasible, but how it would make all of the other problems that Congress is trying to solve much, much smaller, if not make them disappear, including by making health care more universal than it is today. So when we hear about international comparisons of health spending, we usually hear something like what Robin Hanson mentioned in our last panel, which was that the United States spends 16, 17, 18% of GDP on healthcare. That's so much more than any other nation spends. What most people don't mention is the reason we spend so much more on healthcare in the United States is that government compels us to. The OECD finds that compulsory health spending in the United States accounts for 14% of GDP. So the government is compelling us to spend 14% of GDP on healthcare. And the main contributor to that, government therefore ends up controlling a larger share of health spending in the United States than in most OECD nations. In fact, at 85% government control, we're within striking distance of Cuba, which is a communist nation where the government supposedly controls all of the health spending. This should tell us, among other things, that we don't have a free market in healthcare, and one of the biggest reasons for that, and the biggest contributor to that those compulsory spending figures is compulsory spending on employer-sponsored health insurance. The reason that spending on employer-sponsored health insurance is compulsory is that the Internal Revenue Code contains a feature that we call the tax exclusion for employer-sponsored health insurance. What this means is that if your employer gives you $1 in cash wages, you have to pay taxes on it. Income and payroll taxes at the federal level produce an average marginal rate of 33% or so. So you lose about a third of that dollar to taxes if you take that dollar as wages. But if your employer takes that same dollar and gives it to you as health insurance, then you don't lose any of it to taxes. You get $1's worth of health insurance. We call this a tax break. In effect, what it actually does is it says if you want to control your own health insurance dollars and choose your own health insurance, then the government's going to penalize you. It's going to penalize you 33% of that money that you want to spend on health insurance. And in many cases, it'll penalize you even more. And what that leads almost everyone, 90% of the private market in the United States to do is to get health insurance through an employer. And so that spending is compulsory and spend on an annual basis about $1.2 trillion on employer-sponsored health insurance. What that means is that if there's one thing health economists agree on, it's that money comes out of workers' wages, that $1.2 trillion. And if workers wanted to control that money themselves and choose their own health insurance, they would have to lose about a third of that money to taxes. So it is functionally the equivalent of a mandate. The tax code creates what is the functional and economic equivalent of a mandate to purchase employer-sponsored health insurance, which is, by the way, really lousy health insurance. But the key to reforming, and has all sorts of negative consequences. It increases the amount of insurance that people purchase, which leads to higher prices for medical care. But a key feature of the tax treatment of employer-sponsored health insurance is that it denies workers control of that $1.2 trillion of their earnings, and that is also the key to reforming the tax treatment of employers of health insurance in a politically feasible way, because if you reform it the right way, you can give that money back to the workers in the immediate term on day one, which means that if you reform the tax exclusion the right way, you can produce immediate benefits for identifiable constituencies, which is a problem that has bedeviled all attempts to reform the tax code, reform the tax exclusion to date. What this graph shows is that $1.2 trillion and the amount of that spending on employer-sponsored health insurance that workers currently control as a result of tax-free health savings accounts is a tiny sliver. It's 4%. And what I'm going to offer is a way to give workers control over that entire amount in order to facilitate reform and improve the performance of the health sector. So as I mentioned, the tax exclusion encourages more health insurance. As Kenneth Arrow wrote in his seminal 1963 article on the economics of healthcare, health insurance leads to higher prices because it reduces the incentive of physicians and patients to shop around for lower prices. A couple of years later, Marty Feldstein, who ended up being President Reagan's the chairman of President Reagan's Council of Economic Advisors, wrote with his co-author that it can with justice be said that the tax, he called it a subsidy, I call it the exclusion, has been responsible for much of the healthcare crisis because it has driven up prices for healthcare. It has driven up prices for health insurance. It has left people with health insurance plans that are very low quality because they disappear when you get sick and can't work anymore. And by increasing the amount of insurance that people purchase, the tax exclusion has this graph illustrates how that effect dramatically has coincided with a dramatic increase in healthcare prices. As the share of medical spending that people do out of pocket that comes from the patient herself has fallen, prices have risen dramatically faster than inflation. If prices for medical goods and medical services had risen at the same rate of inflation, those two upward sloping lines would just be flat along the x-axis. And this has the tax exclusion's encouragement of more comprehensive health insurance has also, in addition to leading to higher prices, has led to greater consumption of services, higher per capita health spending overall, which then increases health insurance premiums. So how do we fix the distortionary effects that the exclusion has on where people get their health insurance, how much health insurance they purchase, the upward pressure that it places on prices for health care? There have been a number of proposals over the decades, some that would that are politically infeasible, such as my preferred option would be to eliminate the income tax. But even more politically feasible options than that have not been feasible enough, like eliminating the exclusion or just capping the exclusion above a certain level so that your employer-sponsored insurance premiums up to, say, $15,000 or $20,000, those would still be not subject to taxes. But if you purchase a plan that is more expensive than some threshold like $15,000, that amount above $15,000 would be subject to taxes. A cap on the exclusion like that would eliminate some of the distortions, at least at the margin, that the exclusion creates. And that's basically what Congress tried to do when passing the Cadillac tax as part of the Affordable Care Act, even that has proven to be politically infeasible because Congress later repealed the Cadillac tax on a bipartisan basis, almost unanimously. So Congress is really faces some really tight political constraints when it wants to reform, if it wants to reform the exclusion. I think that all efforts to reform the exclusion, however, have so far ignored a great political asset that Congress could be using to get reform across the finish line, and not just get it across the finish line, but get durable reform across the finish line so that a future Congress does not undo it. And that political asset is that $1 trillion of workers' earnings. No reform that I'm aware of to date has discussed what happens or provided what happens to that $1 trillion or provided a vehicle for getting that $1 trillion to consumers. And as a result, opponents of reform have been able to demagogue the Cadillac tax or a universal tax credit or elimination of the exclusion entirely by telling workers that you might lose your health insurance and you're going to be left high and dry and not be able to get the medical care that you need. I think there is an approach that takes advantage of that political asset or turns that $1 trillion into a political asset by giving that money to workers immediately so that they will control that $1 trillion of their earnings that employers now control. And that reform is something that I call universal health accounts. The idea here is to change the tax exclusion into an exclusion not for money that the employer controls and uses to purchase the worker's health insurance, but for money that the worker controls. You could basically, money that the worker controls and puts into a tax-free account and uses to purchase health insurance from any source. If you transform the exclusion from one for employer-paid premiums to one for deposits into a tax-free account for health care and health insurance, then you can make this change on a revenue-neutral basis. You can shift control over that $1 trillion to the workers, and then you can eliminate almost all of the distortions that the exclusion creates in terms of encouraging employer insurance over individual market insurance, or encouraging workers to buy excessive levels of health insurance that drive up healthcare prices and health insurance premiums. And you would need to make these universal health accounts a reality. You need to make three basic changes. The first is you take all the tax preferences in the tax code right now. By far the largest one is the exclusion, but there are some smaller ones for health savings accounts and flexible spending arrangements, health reimbursement arrangements, and so forth. You take all of those tax preferences and you convert all of them into an exclusion for deposits into a tax-free universal health account. What that does is it gives you it gives you a lot more breathing room to make those the deposit limits in those accounts as high as possible. Probably enough, you can make them high enough that most workers could then take all of the money that their employers had been spending on their health insurance, which is really the workers' money, put that into a tax-free universal health account and not face any tax consequences whatsoever. That's usually a barrier to reform when people realize that when the reform might cause some people to pay more money in taxes, they will mobilize to block the reform. Most people would not see an increase in their tax liability because consolidating all existing tax preferences into this new exclusion for universal health account deposits shields most people from a tax increase. You would have to have some limit on UHA, universal health account deposits, and Congress can calibrate those tax limits on tax-free deposits wherever it needs to in order to hit revenue neutrality. So this could also be a revenue and budget neutral measure. But then once you've done that, and I offer 9,000 caps of $9,000 for individuals and $18,000 for illustrative purposes. We don't yet know what those caps would have to be. But then the third change you would want to make is to allow people to purchase any health insurance plan from their universal health account tax-free. And this could be their employer plan, or it could be an ACA plan or any other plan that's legal for sale in the United States. And these three changes would be transformative of the entire private sector for the entire private healthcare sector and the market for health insurance for reasons that I'll be describing in a moment. But I would submit that this is the best politically feasible option that Congress has before it. First of all, it can be a bipartisan reform. There are lots of effects of making these three changes for Democrats to like and lots of effects that Republicans would like. Each party would win more than they would lose. It would improve both efficiency in the health sector and equity on a number of dimensions. As I mentioned before, it's also more politically feasible than past efforts because by transferring control of that $1 trillion from employers to workers, it would provide large immediate benefits to identifiable groups. And because workers could then stay in their employer, use that money to stay in their employer plans if they want, it would be less disruptive than any other reform of the exclusion. And all these changes can happen within the budget reconciliation rules and process that Congress is going through right now. So what are the principal effects of making those three changes? Well, the first thing it would do is it would increase the cash wages of workers economy-wide by about $1 trillion per year as employers shift that $1 trillion from spending it themselves on employer-sponsored insurance to cash wages. Once the tax preference is no longer available for employer-purchased insurance, pretty much overnight employers are going to have to shift that money to cash wages so that workers can avoid tax consequences and put that money in a universal health account. And the people who are going to see, and this is not an insubstantial amount of money that employers would be shifting to wages. For the average family, it would be about $19,000 per year. And it would be greater than that average amount for groups like women, spouses who currently don't get, spouses who get coverage through their spouse rather than through their employer, older workers, union members, workers in high-cost areas, workers with expensive conditions. All of them would get an even larger than average cash out. I like to think of this as sort of an automatic risk adjustment that labor markets would just take care of by themselves, where the money would go to the people who need it more, the people with higher medical expenses. And there are reasons why the economics literature indicates that that's what would occur. Workers could then take that money, put it in their universal health account, and remain in their employer plan if they want. There's no reason that they and their employers can't keep offering that coverage if they choose to do so. But it would completely eliminate the phenomenon of job lock, where workers have to stay with a job just to get the health insurance. It would increase labor mobility and eliminate a barrier that smaller firms face because they can't achieve the economies of scale that larger firms can, and therefore have to pay more money for health insurance and less money in wages, which makes them less competitive in the labor market. It would end that competitive disadvantage for those firms. But it would also make health care or the health sector and the tax code more efficient. In addition to being more efficient, it would make it more equitable. It would shift the tax burden from low-income workers to high-income workers. There would be an explicit tax increase or an increase in explicit taxes for high-income earners because if you are currently excluding more compensation from wages than or from taxes than you could with a cap on universal health account deposits of $18,000. Say you have a $50,000 employer-sponsored plan, $32,000 of your wages, once your employer shifts that $50,000 to wages, $32,000 of it is going to become subject to taxes. That means that high-income earners are going to bear a larger share of the federal tax burden, but they would also see an effective tax cut for reasons that I'll explain shortly. But a lot of low-wage workers are going to have a much greater access to this tax preference than they currently get if their employer doesn't offer health insurance or offers less health insurance than they would like to purchase. They would be able to exclude more money from more of their earnings from taxation. And this reform would also, I think, make the tax treatment of healthcare more efficient and equitable by eliminating the worst features of health savings accounts that cause dissatisfaction with so many people, such as the high deductible health plan requirement, but retain the best features of health savings accounts. What this graph shows is the distribution of the amounts that families and individuals exclude from taxes in the form of employer-sponsored health insurance. And it basically shows you how a universal health account deposit limit of $9,000 for individuals and one of $18,000 for families would work. If you currently exclude more than those caps, you would have to pay more in taxes. But you would also gain control of more of your earnings than you controlled before. When your employer shifts that, if you're one of those high-paid workers with $50,000 of tax-free employer health insurance right now, your employer would shift that $50,000 to your wages. You'd put $18,000 of it in a universal health account, tax-free. You'd pay taxes on the remaining $32,000. You would lose maybe $10,000, maybe $11,000 or $12,000 of that to taxes, but you would still control $38,000 of your earnings that you didn't control before. And that is the political asset that $1 trillion of worker money that employers now control offers us so that Congress can reform the tax code in a way that provides immediate benefits to identifiable workers, to identifiable constituencies. The amount of money that this reform would shift from employer control to worker control, the amount of money that, the amount of their earnings that workers would be able to control that they currently do not rivals the amount of money that the Reagan tax cuts allowed workers to control. That was just about 3% of GDP. Here we're talking about 4% of GDP per year. So a Congress and a president that enacted this reform, they would be even bigger tax cutters than Ronald Reagan was. And would also improve the performance of the health sector. I could talk a little more about how this would work, but I'll just offer you this one visual to give you an idea of the sort of effect that it would have. A series of experiments have shown that when you make individual consumers price conscious, as universal health accounts would, they shop around for lower prices and they force providers to change their behavior and compete on the basis of price, driving prices down for complex procedures like hip and knee replacements by 37% over a 2-year period, as well as for lots of other medical goods and services. So this is how this reform would make healthcare more universal, which helps solve all of the other problems that Congress has been trying to solve for years and years. I'll talk a little bit more about this in Q&A, but now I want to turn things over to Brian Blase so that he can talk about more dramatic Medicaid reforms that Congress is considering right now.
All right, thank you, Michael. And I'm going to talk about some reforms that I hope Congress does consider this year as well. I think panel number one focused on the fact that we have enormous amounts of health spending that doesn't provide Americans with value, and we would be much better off if we reduced medical expenditures. Another really important thing going on right now is that the U.S. fiscal position has severely deteriorated. Last year, the federal government ran a $1.8 trillion budget deficit, and those budget deficits are set to continue for the foreseeable future. Fiscal policy is completely unsustainable. It shows that Washington just isn't serious about grappling with the trade-offs necessary to make in sort of the core responsibilities of governing. And health care component of the federal budget, Medicaid, Medicare, and the ACA, is the only part of the budget growing faster than the economy, save net interest payments on the debt. If we don't get control over the federal spending problem, Americans' future prosperity is at stake. Like, we're going to have higher interest rates, we're going to have higher inflation, and we're going to have a lower standard of living. 2 years ago, I commissioned a study from Paul Winfrey, who is now the head of EPIC, really looking at how the healthcare programs were contributing to the deteriorating situation, and what we needed to do in order to get back on track and avoid what he referred to as a debt spiral. And basically, we need to come up with health savings of about $2 trillion relative to baseline to put our federal health programs back on a sustainable trajectory. I'm going to spend most of my time talking about the Medicaid program because the Medicaid program this year is the one that Congress is going to debate making reforms to. I'm also going to mention a major issue with Obamacare that's going to be in front of Congress this year, and then I'm going to finish with a thought or two on Medicare. So let me start with Medicaid. The key to understanding Medicaid is that the federal government provides an open-ended reimbursement of state expenditures. On average, historically, it was about 60%. So a state would spend $1, the federal government would reimburse that state 60 cents. So if you're from a state perspective, you only have to get 40 cents of value to justify a $1 expenditure. Now that's a bad set of incentives. But the situation is actually far worse than that indicates for two reasons. One is a provision of Obamacare that added a new class of Medicaid eligibilities, able-bodied working age adults, and for the first 3 years reimbursed 100% of the cost. That reimbursement has gone down, but it's 90% now. So states only have to get 10 cents of value to justify a $1 expenditure on an able-bodied working age Medicaid expansion enrollee. But it's worse than that because states don't need to actually come up with their share of the spending. They have big incentives to create financial gimmicks which give the appearance of a actual expenditure, but it's just a financial gimmick, and I'll go through an example of how that works, so that the federal government is reimbursing states for what is essentially money laundering. And I think there's ways for Congress to address some of these, reduce some of these major problems. The biggest Medicaid reform, and one that I fully support, would be capping the amount of money that the federal government sends to states. I think it is something that was put forward in the 1990s. Actually, a Medicaid block grant proposal got to Bill Clinton's desk. It passed both the House and Senate in the mid-90s, and he vetoed it. But a block grant would align state incentives so that every marginal dollar came from the state tax base. So the state would have incentives to make sure that the value that they get through the Medicaid program was worth that dollar expenditure. Okay. I have a lot of slides that I'm going to go quickly through, and I'm going to skip some, but they'll all be available. Michael will make them all available for you afterwards. With Obamacare, so some of these, I'm going to start with some of the problems that came with Obamacare. With Obamacare, improper payment rates in Medicaid exploded. So the improper payment rate was about 6% before Obamacare. The Obama administration actually stopped doing improper payment reviews for the first 3 years of Obamacare. When they restarted, massive problem, largely because states just stopped doing eligibility determinations. So if the federal government's paying 100% of the cost, states have no incentive to make sure that someone is eligible in order to qualify for the Medicaid program. Improper payment rates shot up to the point where they were almost 1 in 4 of all Medicaid spending was improper. Low value of care in the Medicaid program. One of the best ways to measure whether our programs are providing people value are to ask them how much cash they would take to opt out of the program, right? And they would take a small amount of cash to opt out of the Medicaid program. Economic estimates were that they would only take about 20 cents on average, and you get about half of Medicaid enrollees to drop out of the Medicaid program and take the 20 cents on the dollar instead. This is a very important point and something that we are really emphasizing now with lawmakers. It's that the federal-state partnership here has gotten out of whack. Historically, the federal government paid 57% of the Medicaid costs. With Obamacare's expansion, that increased, and with COVID policies, that further increased. So now the federal government's paying about 67% of the share. Now, that is actually an underestimate of the federal share because, like I mentioned, states develop financing gimmicks so that you give the appearance that some of the state expenditures are not real. GAO did a study in 2018 that found if you actually accounted for the fact that states employ all these financing gimmicks, the federal share would increase by another 5%. And these financing gimmicks, they did this study back in 2018. The financing gimmicks have increased substantially since 2018. At Paragon, we refer to this as Medicaid money laundering, and I'm going to give you an example. And Mark Miller on the previous panel talked about them. I'm going to give you an illustration here of how the Medicaid money laundering works. The most common example of that is something called a provider tax. Now, to call this a tax is a gross abuse of the English language. It is not a tax if the recipient of the tax develops the tax and lobbies the government to assess it on them, and when one is in place, then lobbies the government to increase it on them. Like, no tax has that feature. But yeah, we call these Medicaid provider taxes. Here's the economics of how they work and how they produce wasteful additional spending in the Medicaid program. So in a world with no provider taxes, assume a 60% federal reimbursement, which is the average reimbursement. The state makes a $100 payment to the provider. The state then submits that $100 to the federal government. They get 60% of that reimbursed. So the federal government pays $60, the state pays $40, the provider makes $100. Okay, well, the providers in the mid-1980s started to get creative, and at first they developed what they called donations, provider donations. Then they reframed this to a provider tax. Provider said, why don't we give you $100, state? You make the $100 expenditure, you make a net $100 expenditure on us, so the state would have to pay $200, and you, state, will be better off with this arrangement. So you could see in example 2 how provider taxes shift the costs from the state to the federal government. The state gets the $100 tax, makes the $200 payment to the provider, so the provider is still up $100, but the state is now submitting a $200 claim to the federal government, getting 60% of that reimbursed. So the federal government's out $120. The state makes $20 from this arrangement. The provider makes $100. Of course, what provider taxes do is increase the total amount of Medicaid spending. So this example 3 shows the state is much better off using the provider tax than the no provider tax scheme. In this case, they tax $100. The state makes a $250 payment to the provider, so the provider is now up $150, and the state submits a $250 bill to the federal government, gets 60% of that reimbursed, which is $150. So you can see the federal government is out the $150. The state is neutral here. The provider gets $150. So provider taxes cause a massive shift from the state to the federal government and raise overall health care spending. Now, when I was writing my dissertation, I did one of my chapters on provider taxes, and I was also reading Bob Woodward's book, The Price of Politics. And when you're writing your dissertation on something that you think is a kind of obscure topic, and you realize that that topic made its way into the highest levels of budget negotiations, you get really excited, and you're like, I have a great hook for my dissertation chapter. So in 2011, this is hard to believe now, 15 years later, but there was concern about the federal deficit in Washington, bipartisan concern. President Obama talked about the fact that Medicare and Medicaid were on an unsustainable trajectory, and we needed to reform them. Congressional Republicans were serious about the effort. The Tea Party wave had just taken over Washington, and there were high-level negotiations. They started with President Obama and Speaker Boehner. Those broke down, but then they resumed with then Vice President Biden and then House Majority Leader Eric Cantor. And this is a part of the book that I'll read with you. This is what made me so excited when I was writing my dissertation. The congressional Republicans brought up the idea of limiting provider taxes. And this is what Woodward wrote. It's a scam, Biden agreed. The states were gaming the system, taxing doctors and hospitals so they could get federal reimbursements, and then returning the money to the providers. Let's call it like it is, and let's just do this. It could save $40 billion. If we can't do this, Vice President said, come on. Washington Post. So the Obama administration in its budget proposed phasing down provider taxes. It's complicated. I'm not going to get into the details, but they proposed limiting states' ability to use provider taxes. It was actually it was in President Bush's budget, President Obama's budget, and President Trump all proposed this reform. And the Washington Post did an editorial in 2012 titled "A Much-Needed Medicaid Reform," and this is an excerpt. A bit of a charade, has Senate Majority Whip Richard Durbin described the provider tax scheme. As Mr. Durbin's remarks suggest, reform is a bipartisan idea. President Obama's last budget would have reduced the permissible provider tax to 3.5%, saving $21.8 billion over 10 years. This is, if you are going to have an open-ended reimbursement, you have to make sure that the state expenditures are legitimate expenditures. On the other side of this are the payments now that states get using these provider tax schemes. And this is a really important and new development in the Medicaid program. But using something called state-directed payments, which are the state directing the health insurer to pay providers up to a certain amount. So the state is directing the insurer to pay healthcare providers up to certain amounts, and they are now having Medicaid payments to providers up to average commercial rates. You know, Michael said that Medicare is overpaying for a lot of services, and I agree that Medicare overpays for a lot of services. Average commercial rates on average are 3 times Medicare rates. So providers through the Medicaid program are now getting 2-3 times as much as they get through the Medicare program, which really is this feature of money laundering where the state is spending entirely with federal dollars and then are rewarding the politically powerful hospitals in their states with rates that are up to average commercial rates. I fully support Mark's suggestion in the first panel that we should cap the payments through these state-directed payments to Medicare rates, and that healthcare providers should not be making windfall profits through a welfare program. Okay, those are our recommendations. We think addressing Medicaid money laundering is a very serious policy that Congress needs to consider this year, has had bipartisan reform in the past, and Paragon's going to be producing a major report on Medicaid money laundering with a set of recommendations next month. The next reform is to the 90% Obamacare match rate. It doesn't make any sense for the federal government to reimburse 90% of state spending on able-bodied working-age adults and a much lower percentage of spending on kids on the program, people with disabilities on the program, and pregnant women on the program. So this is a cover art for our Medicaid financing reform proposal, which would be coming in and pushing down policies so that it's brought back into balance between these two groups. What we did is put together, I think, a thoughtful proposal illustrated by this graph. The way that Obamacare currently works is that enrollees above 138% of the poverty line are enrolled in the exchanges with a premium tax credit. Below that amount, federal government's reimbursing 90% of the cost, and that 90% is a fiction. The federal government's paying basically the entire cost because states are using financing gimmicks to finance the state share. What we would do is transition for enrollees below 100% of the poverty line over a decade period, the federal reimbursement from 90% to what states get for all their other populations on the Medicaid program. And for individuals above 100% of the poverty line, those individuals would transfer to the exchanges. Now, no one would lose coverage through this proposal unless, to Michael's point, states don't value keeping expansion when they get the same federal subsidy for the expansion population than they get for all the other enrollees on the program. We think that this reform, and we worked to try to model it with how CBO would estimate it, we think this reform will save over $500 billion over the next decade. Final Medicaid point, and this really illustrates that the program's financing does not work anywhere like the way that it was intended to work. why don't we just allow states to keep their own money? Why do we transfer it to Washington and then send it back to Washington? Why can't we just say, states, you're going to take care of your lower income population? Well, the argument was made that poorer states can't afford to do that. So we need a program that will provide more federal financing for lower income states. So the federal government reimburses a much higher share of Medicaid spending in poorer states than it does in wealthier states. If the financing, so this graph shows the horizontal axis is state per capita income, and the vertical axis is federal Medicaid spending per person in poverty. If the Medicaid formula was working and the federal government was providing more support to lower income states, this would be a downward sloping line. Right? The fact that this is upward sloping with a correlation coefficient of 0.5 shows that the Medicaid financing is not working anywhere like it was expected to work, and we're actually transferring far more money to wealthier states that have grown more profligate Medicaid programs than poorer states. The solution to this, in our view, and this is also in that financing paper as proposal number 2, is to reduce the floor on the federal reimbursement. Congress set it at 50%, and we would gradually reduce that reimbursement so that wealthier states have to pick up a bit more of the expenditures for their Medicaid program. Okay. I am going to talk now about the ACA. So this is the most impactful paper that Paragon has released to date. I titled it, so I'm very proud of this title, and the cover art was not me, but I love the 3-card Monty player. The Great Obamacare Enrollment Fraud. So here is the reason why we have the Great Obamacare Enrollment Fraud. It's explained in this figure. The original subsidy design is in blue. So the way that the ACA subsidies work is that the federal government limits the amount of household income that a household has to pay for a benchmark plan. So for the lower income households, they had to pay 2% of their income for a benchmark plan under original Obamacare. And as household income went up, people had to pay more of their income for the benchmark plan. And then at 400% of the poverty line, the subsidies weren't available for households above 400% of the poverty line. In the American Rescue Plan Act and the Inflation Reduction Act, President Biden signed a significant expansion of the subsidies. And that expansion is illustrated by the orange line. And the key thing is this 100 to 150% of the poverty line group. For that group, they have to pay 0 for a benchmark plan. Now, a benchmark plan for this group has a 94% actuarial value, meaning it's an insurance plan that has very low deductibles, very low copayments. If the enrollee, for some on the left, they think this is a great design because it significantly expands coverage. You're expanding coverage to people who they think can't afford it otherwise. But if you think about the value proposition here, you are expanding coverage to people who don't need to get any financial value from the product in order to sign up for it. Also, the ACA's subsidy structure is complicated. It involves you, the individual, estimating their income in advance, and then the subsidy amount that they qualify for is sent to the health insurer. And then there's a reconciliation process. But if people get too much subsidy during the year, they don't have to pay back as much after the reconciliation process. And for some individuals, they don't have to pay anything. What we did in our report is compare signups in this low-income category that qualifies for the free plan. So signups under 150% poverty line with actual people that live in the state that would be eligible for the program. So people that don't have employer-sponsored insurance or another government plan. In 9 states, there are more people enrolled in the exchanges than live in that state who would be eligible for the plan. In my state of Florida, I moved to Florida, we have 4 times as many people enrolled in the exchanges reporting income that qualify for a zero premium plan than live in the state of Florida that have income in that range who would be eligible for the plan. Nobody does for healthcare fraud like the state of Florida. We're very proud of our healthcare fraud in Florida. Government programs should not be operating like this. There should not be fraud on the magnitude of 20 to 25% of all expenditures, all enrollment and expenditures through this program are fraudulent. And it also contributes, if you think about incentives, the incentives for insurers now who get most of their revenue from the government, they like getting payments from the Treasury. It's much easier than having to provide a plan that a patient values and will use their own money on. Getting money from the Treasury and lobbying Congress to keep the money flowing is much easier from the insurer perspective. Brokers realize that a lot of people won't pay any money for these plans, so they have been manipulating applications to have people have the appearance where they qualify for zero premium plans to enroll. So you've got really bad incentives for insurers, for brokers, for enrollees, and the federal taxpayer holding the bag. There's several recommendations for how to fix this problem. The biggest one by far, and a major policy issue this year, will be what to do with these enhanced subsidies because they expire after 2025, and Congress should do no harm here. It should just let those enhanced subsidies expire. Let me say 2 more things quickly, David. 2 more policies, and I'll just mention them. HSA option. So this is a paper on our website. We think that one of the major principles that should motivate reform are to get money away from the insurer and the provider and get it directly to the individual. So in this paper, we propose a policy that would take a portion of the Obamacare subsidy that now goes to the individual insurer to reduce deductibles and copayments, and we would send it to the individual as an HSA account so that the individual has control over the money. And the last thing I would mention is our Medicare Advantage reform proposal. I agree that, so this is our Medicare Advantage reform proposal. We've put a lot of time into this proposal. It took us about over a year to figure out what the policy should be in constructing a balanced MA proposal. I agree with many of the things that Mark said on the previous panel. There's benefits to MA, but there's ways to improve the program. Its quality bonus program is deeply problematic. The risk adjustment and the coding intensity are deeply problematic. And we have a proposal that would reform many of the inefficiencies within the MA program and save what we think is at least $250 billion over the next decade.
Thank you, Brian. I tend to think that Medicaid gives money laundering a bad name.
I know you do.
Money laundering is sometimes morally permissible, even praiseworthy, but
socially optimal.
Yeah, never is our Medicaid provider taxes either of those things. So thank you, Brian. And now we'll turn things over to Cato adjunct scholar David Hyman.
Thank you, Michael, and Brian, both for their remarks, and Cato for putting on this event, and the really marvelous graphic behind us. I actually timed it. That patient has 6 heartbeats per minute, which looks cool, but is not consistent with life. And so I think if we want to display a higher degree of
Who invited the doctor?
clinical sophistication, we might want to speed it up a little bit. So, at any health policy event, you'll hear about a bunch of things. One of them you'll hear about is how much Americans are spending on health care and serious questions about the value and highly variable quality depending upon where you live and what kind of health insurance you have. And sooner or later, you'll also see at least one graphic from the Dartmouth Atlas that'll show huge regional variation in treatment patterns and huge variation in spending. And because it's Medicare data, there's a small price effect, but it's mostly a volume effect that's capturing. And that's really wonderful work done by the Dartmouth team, including Jack Wenberg and Elliot Fisher. But I wanted to call attention to Elliot's lesser-known brother, Peter Fisher, who was Undersecretary of the Treasury during the Bush 43 administration. And he has this quote that I included in an article a while back that I just wanted to read to you. Think of the federal government as a gigantic insurance company with a sideline business in national defense and homeland security, which does its accounting on a cash basis, only counting premiums and payouts as they go in and out the door. An insurance company with cash accounting is an accident waiting to happen. Well, that's our government, right? It's an insurance company first and foremost with a small sideline and a bunch of other things, all of which we also value. But our spending priorities reflect our priorities, and our priorities are we've built an insurance company on a cash basis that is basically a financial and demographic time bomb. And it's a big, slow-moving problem. One of the core things about Washington and about government more generally is we don't do so well with big, slow-moving problems. It's always easier to kick the can down the road. Every year there's a trustees report that talks about how the Medicare Trust Fund is going bankrupt. The only question is it 5 years, 6 years, 8 years? In a good year, it's 10 or 12 years, but it's always coming and coming soon. But we'll respond to that by usually relatively small tweaks at the margin rather than taking a serious look at our spending levels and spending trajectory. And as you've heard already today, the part of the federal budget that's growing faster than the overall economy is healthcare and interest on the national debt. And a big chunk of the reason why we have interest at the level we do is because we're doing deficit funding of the insurance parts of our government. And so what does that imply? Well, job stability for those of us who come to these sorts of conferences and talk. But more importantly, that we're not willing to make hard choices, at least not publicly, unless there's a real crisis that prompts re-examination of the core issues. And I think there are a couple of reasons for that. Some of which are particular to healthcare. I'll come back to that at the very end. But the second point I want people to understand is that at the federal level, health policy is spending policy, and spending policy is health policy. We don't regulate healthcare providers directly at the federal level. We just pay them. And how we pay them, how much we pay them, and who we pay in what relative amounts has a profound impact, not just on the budgetary picture, that's fairly straightforward, but on the distribution of services within and across different states, how easy or hard it is for you to find a doctor if you're covered by Medicaid as opposed to Medicare, and also, consolidation in the industry, single specialty hospitals, ambulatory surgery centers. I could go on and on with these things, but our time is short. And I wrote a whole book about this that you can go buy if you're really obsessed with these issues like I am. But the third point I want you to understand is that Medicare and Medicaid, and actually health insurance more broadly, functions like a defined benefit plan. We basically promise whatever the healthcare system says you'll need, we'll figure out a way to pay for it. Sometimes all of it, often most of it, co-payments, and the patient share of spending, as you've seen, has dropped very dramatically over the course of the last century. There didn't used to be health insurance. Health insurance got created because doctors and hospitals got worried about actually getting paid by their patients, and so they figured a risk pooling as well as a healthy subsidy from state and federal governments was a way to solve that basic problem, which also obviously has implications for the politics of changes in those payment policies, as well as dramatic cutbacks of the sort that you heard about from Robin in the first panel. Let me talk just a little bit about Medicare and Medicaid from the perspective of a defined benefit plan, as opposed to what's much more common in the modern economy, which is a defined contribution kind of pension plan, rather than an open-ended promise to cover things. Our retirement system, the private part of our retirement system, is if you want money, save some money, and we'll specify how much we're going to contribute, but we're not going to make an open-ended promise that will cover the risk of inflation and will pay you X percent of your salary, whatever it happens to be. And it's not a surprise that we moved that way in the pension side of the equation, but we haven't seen a similar evolution on the healthcare side of the equation. We still have the same open-ended promises, open-ended commitments, open-ended reimbursement of whatever the states have decided to spend on their Medicaid beneficiaries. That doesn't work out so well, right? It doesn't work out so well from a budgetary perspective. It also doesn't work out so well from a quality of care perspective, and making kind of rational trade-offs about, is the highest and best use of an incremental dollar for someone spending it on health care as opposed to spending it on housing, food, recreation, exercise, entertainment, travel, right? You can go through all of what you might think of as a basket of social determinants of health and quality of life. The empirical evidence, some of which you heard about in the first panel, I think is pretty clear that most aspects of our healthcare spending don't meaningfully contribute to better health. The big gains were realized early and often through public health focused initiatives like sanitation, immunization, nutrition. And the miracles of modern medicine notwithstanding, right? If you've got meningitis, you really need antibiotics. And that's not the 50% of healthcare spending you want to cut by any means, although we do overuse antibiotics simultaneously, which indicates the complexity of this problem. The reality is we funnel a huge amount of our social welfare spending through our healthcare budget rather than through what might make much more sense if our goal was broadly conceived population health. And if you look at how people make their own spending decisions, they value healthcare, but they value all sorts of other things as well. But we subsidize healthcare to a degree that we simply don't other areas of the economy. Which brings us to the suggestion that Charlie Silver and I, in a series of articles, made as to reforms, fairly dramatic reforms to both the Medicare and the Medicaid program. For Medicare, focusing on shifting it to look more like Social Security. Now, Social Security is immensely popular. Giving people money makes you immensely popular. Medicare is immensely popular among doctors and hospitals, much more so than Medicaid, and it's popular among beneficiaries as well. But I submit to you it would be even more popular among beneficiaries if it gave them money directly or gave them a restricted savings account or a voucher plus a catastrophic coverage plan than its current open-ended promise. And the amounts of money that are at stake are really pretty material. The sort of median spending on a Medicare beneficiary is $15,000. Now, some people use that and more. A lot of people don't use a material amount. Lots of people, particularly the younger Medicare cohort, are relatively healthy. But that's a lot of money that, if put in the hands of beneficiaries, they could use to drive very different healthcare system than the one we see today. You wouldn't have to worry about site payment neutrality because no one spending their own money would go to the overpriced offering, right? Maybe some people go to the dealership to get their oil changed, but there's a reason why there are lots of lower priced alternatives, because people spending their own money sort these things out immediately. And if you're interested in asking questions about value, well, who's the best judge of value? People. For themselves, right? Any other circumstance, you get an agency problem, it's prone to lobbying and all of the sorts of abuses that give rise to the kind of situation we're seeing here. For Medicaid, in a different paper, we talk about using a similar strategy to motivate the states that are holdouts from the expansion, the 10 states that haven't opted in to the Medicaid expansion, to meet them where they are and offer them a approach that caps their exposure, right? Because the open-ended commitment that states that have a low tax, low spending model are unwilling to opt into. And so the idea here is not to cut health care at the expense of the least fortunate. It's actually to expand the benefits, but reframe it in a way that actually causes providers to do a better job serving patients' interests rather than the interests of the current payers. So that's obviously a very brief sketch. There's much more detail in the papers. Let me just now pivot and talk a little bit about the politics of any attempt to make any dramatic changes, or for that matter, minor changes in healthcare payment policy. Washington, D.C. is politics, right? It's the lifeblood of the local economy as well as the day-to-day business of the operation. And healthcare and Social Security are the electrified third rails in that political setting. Attempts to directly cut spending for a visible group of people will trigger immediate complaints about death panels, about rationing, about do you just hate poor people or you want people to die. And that's an important part of the reason why our healthcare system and our budgetary policy look the way that they do. If you want to change that dynamic, you're not going to be able to do it by jamming this down people's throats on a single party vote basis. You're also not going to be able to do it without material public support for whatever it is that you're proposing. And as Robin mentioned earlier, people like and trust their own doctors. They really don't like politicians very much. I know it's bad. I'm sorry to tell you this, but they don't like or trust politicians. They don't like or trust insurance companies. They're not so keen on drug companies either. And that is going to complicate the politics. If you want to disrupt the status quo, you need to figure out a way to enlist patients on your side for whatever the reform is that you're proposing. And once again, the best way of doing that is getting them involved in it by giving them money directly rather than funneling it through other people. Now, let me close by making one point to reference, recent events. So USAID is a relatively small part of the federal budget, and a fairly dramatic attempt to, shall we say, reorient / perhaps eliminate the agency has triggered litigation, street protests, lots of television coverage, even though if you poll Americans, what you will discover is they really don't like foreign aid at all, and they don't like government bureaucrats. And this is an issue that's at the focus of those 2 points, and nonetheless, it triggers a pretty significant backlash. So you ain't seen nothing yet if you try to take on Medicare or Medicaid with a straightforward attack, unless you've got a plan for enlisting public and popular support. And if you don't believe me, you should look back at what happened when we did the Medicare Catastrophic Coverage Act. Michael's grinning because he knows the story I'm going to tell, where Dan Rostenkowski, chair of the House Ways and Means Committee, was chased down the street by a bunch of angry senior citizens waving signs, organized by someone who's currently in Congress, Jan Schakowsky from Illinois. And months later, the Medicare Catastrophic Coverage Act was toast because it had the cardinal offense of front-loading the spinach and back-loading the dessert by forcing the beneficiaries to pay for the benefits they were actually going to receive, which was a drug benefit and greater protection against catastrophic health care spending, which with my law professor insurance law hat on is actually how you should be designing an insurance product to deal with catastrophic problems, not first dollar health care spending problems that are quite likely in terms of when they happen, but also relatively modest in terms of their magnitude. So with that happy thought that healthcare is intensely personal, and if you want to make big changes, you better be prepared for the pushback. I'll stop. Thank you very much.
Thank you, David. So we're having this conversation while Congress is putting together its budget for really for the next 10 years. And Brian, you had some news you were breaking earlier about the allocation to education and commerce?
Yes, so it's not the budget for the next 10 years per se. I mean, I guess it sort of is. It's the budget resolution that needs to precede the reconciliation bill. Sure. So they give the instructions to each committee on spending or saving amounts. And from what my team told me, the Energy and Commerce Committee, which has jurisdiction over Medicaid and some of Medicare, was given an instruction of $900 billion, about $900 billion, which means they will
cut $900 billion.
They will need to come up with, yes, $900 billion of savings.
Over the course of 10
a decade,
years.
yeah.
10 years, okay. So $900 billion over 10 years is what they're envisioning for the Medicaid program and probably Medicare as well. President Trump, during the campaign, said he didn't want to touch Medicare at all, so that's not very popular. It was sort of an interesting irony of the presidential campaign that the Democrat was more open to Medicare cuts than the Republican was, although she said just minor cuts. But if that's all of their proposed cuts, is that adequate? For reference, let's see, because first of all, a couple things about that number. That would not, if they reduced federal spending from projected levels by $900 billion over the next 10 years, that would not be a cut, that would be a reduction in the growth of federal spending. The federal spending is going to grow over the next 10 years, CBO projects by maybe $5 trillion. So this would be less than a fifth of that. So it's not a cut, it's a reduction in the growth of federal spending. Is that anywhere near adequate? And another reference point is, I put up earlier the graph that I did of the proposals that I put in my book and sent to the Doge. And the numbers that I came up with in that proposal, in order to eliminate the primary deficit by 2027, I think I had spending reductions in there that were about $900 billion per year rather than over the course of 10 years. So any comment on the fact that the reductions in the growth of federal spending, health spending that Congress is contemplating are a tiny fraction of what is necessary to bring the budget to balance?
Sure. When we talk about cuts, I think you're right, because the media talks about cuts a lot. Cuts means reduction in the growth rate, right? It's a cut relative to the baseline. I don't think $900 billion is sufficient. I also think if we got $900 billion of meaningful Medicaid reforms, that is a good start, because I don't think we have done entitlement reform that has saved $1 trillion ever. So it'd be a good start. The number that we put out from the Paul Winfrey paper, where he did a sophisticated modeling of something called fiscal space, was 1.7 trillion. So the goal that Paragon has is 1.7 trillion. And we then put out a paper called Reducing Red Ink a few months later that laid out more than $2 trillion of spending reductions. And I would say on the Medicare point, like, we need to reduce spending in the Medicare program. Medicaid is it's in the news now, and there's significant reforms that are needed to Medicaid. But Medicare is the bigger problem, and to just take it off the table is fiscally irresponsible. I don't think President Trump took it off the table completely. I think with the emphasis on DOGE, that they are looking at waste, fraud, and abuse. And I think we need to be expansive in what we consider wasteful expenditures. So overpaying health insurance companies through MA, that's a wasteful expenditure. Overpaying for services in hospitals, twice as much as they could be done in physicians' offices. Those are wasteful expenditures. Reducing those payments doesn't harm beneficiaries. It actually helps beneficiaries.
David?
Can I just jump in on that? Yeah, it's really hard to get solid numbers on the triumvirate of things that everybody can agree we should get rid of, right? Which is fraud, waste, and abuse. Long ago, I wrote an article that tried to get to the bottom of some of the numbers that were being thrown around, and it literally turned out the secretary of HHS was going to give a speech, and he called somebody in the bowels of the building and said, I need a number to put in my speech. And the person on the other end of the line said, let me ask the people in the office. And they averaged the numbers and said 10%, right? And that's hardly a scientific issue. There are better studies of what's called the improper payment rate, and in Medicare, Medicaid, those numbers range, 5 to 7%. That's both an under and an over-inclusive measure of those three things. If the paperwork is in order, it's a proper payment, even if the service was never rendered, even if the beneficiary and the doctor don't actually exist. There's a name and a number, but no actual patient and no actual services. So like lots of programs, the reality is, what does the paperwork indicate? The conventional figure in the health policy circles is that something like 25 to 30% of healthcare spending falls within that bucket, with waste accounting for a disproportionate share. But those numbers, frankly, are kind of squishy. But those are huge numbers, particularly relevant relative to a huge spending on Medicare, Medicaid, and on health care more generally. It sort of is layered through the entire system.
So President Trump took Medicare. Republicans appear to be taking Medicare off the table, but you don't, David. You suggested changing Medicare from a program that provides health care subsidies to people to one that gives them cash like Social Security does.
Yes.
Now,
I should also add, I think if you're not willing to do that, you should certainly be looking at competitive bidding for Medicare Advantage, and then use that to lever down spending on Medicare.
My question has to do with the health effects of that sort of change. We just had a panel where we were talking about how the evidence suggests that we could reduce health spending dramatically without affecting overall health. And you are talking about changing the form of the subsidy that Medicare provides to people from in-kind to cash. But that's different from a different question from the level of spending that Medicare will still issue. How can, if Congress converts Medicare to a cash transfer program, in your estimation, how much could Congress cut without harming overall health, or health for the average Medicare enrollee? Once it gives them that money as cash, can Congress then reduce Medicare spending, and if so, by how much, before there are any adverse health effects overall?
Yeah, 50% seems like a big number. I think numbers closer to 25% seem more consistent with the fraud, waste, and abuse figures that I was just discussing. And that's probably overly generous in some areas of the country and less so in other parts. Florida is ground zero for healthcare fraud. It's a target-rich environment for enforcement.
So when you say waste, fraud, and abuse, you are talking not just about improper payments in the sense of actual fraud, where there's no healthcare provider and no patient, is just people got some codes and they're billing Medicare and taking money and putting it in an offshore account.
Well, fraud, just to be clear, fraud's much more than that, right?
So but that's the cleanest example of it. You're also including in waste, fraud, and abuse this sort of zero value services that we were talking about in the last panel, that the Dartmouth Atlas says could be up to 30%.
Yeah, both zero value, and if I had, my health econ hat on, I'd say services whose value is not remotely near its cost.
Right, so that would be low value, but if the Dartmouth Atlas says it's 30%, the zero value is 30%, and then there's fraud on top of that, which is how much?
10%, says the Secretary of HHS.
Does that make 30%, 40%, 50% look more feasible?
It depends on how aggressive you want to be out of the gate, right? I mean, I think it's a potentially realizable savings. And to be clear, the gains of switching are not simply or primarily the ability to reduce the amount of money that you're funneling through. It's to dramatically improve the quality and value of the services that are being purchased, because suddenly you've solved the agency problem. You still have an informational problem, but you don't have the agency problem.
My next question is mostly to David, but also to Brian. You talked about,
Pick on him.
yeah, but you talked about the politics of spending cuts. And you mentioned USAID and the huge flap about cutting spending there. There's also been efforts to reduce NIH spending by not that much.
Overhead.
And
Well,
sure.
indirect costs,
Sure,
which is
sure. Which for academics, big deal.
for administrators of academia.
Sure. So,
Researchers are suddenly
but
looking
still,
at more money.
I forget what NIH's share of HHS spending is, but Medicare and Medicaid account for 85% of spending at HHS. And so the waste fraud, NIH spending cannot be as much as Medicare and Medicaid spend on waste and fraud and abuse. And yet we're also seeing pretty substantial pushback against really minor efforts to constrain spending at NIH. I'm agreeing with you that we would definitely see pushback against the sort of dramatic cuts that we're talking about here in Medicare and Medicaid. What changes need to happen to the politics of healthcare so that Jan Schakowsky doesn't get seniors to surround Dan Rostenkowski's car, or if they do, there's enough countervailing pressure, political pressure in the other direction that cuts can actually carry the day?
Yeah, so 2 points. First, I just want to provide a little additional explanation for the people in the audience and online who are not necessarily enmeshed in this. NIH is the National Institutes of Health. It's part of the Department of Health and Human Services. It funds all kinds of research in the biosciences. There's like 20 different institutes. They also do some research themselves, but a huge part of it is sending money out to researchers elsewhere in the country. And it's a highly competitive grant process. As part of that, the institution at which these individual researchers work receives an additional sum of money, which is called indirect cost recovery, which, depending on your point of view, is to cover all of the wonderful things that they do that makes the research possible, or is alternatively a slush fund for the provost and the chancellor to spend on private jets and nice carpeting and so on and so on. And the statutory ceiling on indirect cost recovery is dramatically over the newly imposed number that the administration announced. They basically said, we're not going to pay more than 15% because privately funded foundations won't pay more than 15%, and we don't want to be chumps. We're not going to pay anything more than that, even if we used to pay you more, and sometimes there were individually negotiated deals of 50, 60% load on top of whatever the grant research was. So from the perspective of the institutions that received this money and built their infrastructure around its continued flow, this is a significant cut on the order of what Robin was talking about, and you've seen their reaction, right? They bring out researchers to say it's going to destroy us and children will die and that will be on you. And that's the symbolic blackmail strategy that I talked about already. And if you want to address that, you basically need a compelling story that points in the other direction and says, no, you're just trying to protect your vested interest, and the children will be just fine, and more and better research will be done because the money will be redirected elsewhere. So the response to the Rostenkowski story is to figure out how to get the beneficiaries on your side to say, no, I like this proposal. The doctors don't like it, the hospitals don't like it, but the beneficiaries love it, and that's a much bigger voting block. And the way to do that, the simplest way to do that, is to give them the money and let them make their own spending decisions, rather than trying to tell them, here's a great policy, that you value at 20 cents on the dollar, as the, Amy Finkelstein study of the Medicaid program indicated, 20 to 40.
Right?
I think at a macro level, the healthcare industry is increasingly reliant on their revenues from the federal government, right? So the problem of reform is harder than it was in the past because so much revenue that the providers get now is from the federal government. You see insurance plans that are opting out of commercial coverage because there's so much money to be made in Medicare Advantage and fee-for-service or Medicaid managed care. I got into, we all want major entitlement reform. Like country needs major entitlement reform to get back to like principles of limited government. We need to have entitlement reform. It does seem from one perspective to have major entitlement reform, and David I think you mentioned this, that you need bipartisan buy-in, right? You can't have one party just do major entitlement reform on its own. It's just too politically challenging. So that moment that we talked about that I mentioned from 13, 14 years ago, where we had the fiscal commission and the super committee. We did have an opportunity there, and I think they got reasonably close on major entitlement reform, but ultimately the politics prevented them from sealing the deal. I think what Republicans are trying to do now is they've got a very complicated set of policies in front of them on expiring tax cuts from the 2017 law that they want to extend. And doing that would significantly increase the deficit. So if you're going to pursue fiscally responsible policy, you're going to try to offset a portion of the cost of the extension of the tax cuts. So they're looking at healthcare, and they're looking at what are things that you could do on a pretty much Republican-only vote to reform healthcare programs. And so that's what sort of the environment we're operating in. And we have focused on, there's two areas that you should target. One is the 90% Obamacare expansion rate, that it makes no sense to pay more for able-bodied. It has taken resources away from kids and people with disabilities, and we have studies on this that show that has happened, and to gradually reduce that 90% over a decade. And then the second is, and really when you talk to members of Congress or the average public about how the Medicaid program is financed and that it is kickbacks and money laundering, like just should government operate like this? And most people will say no. But there you're going to run into obstacles from both the hospitals that are now getting paid much more for Medicaid than they are for Medicare, which is a very different political dynamic than when you were looking at entitlement reform a decade or two ago. And states that don't want to do this spending, right? States could, to your point on the first panel, they could keep the entire Medicaid program regardless of the federal size of the federal payment reductions, but they would have to pay more. Well, what state politician wants to be like, sign me up for that deal, where I have responsibility over what the state taxes are?
So a couple of questions from our online viewers, from Anonymous, maybe the same Anonymous, relate to each other. One is regarding the universal health accounts idea. Do you think employers would actually shift those healthcare dollars to workers? And also related, how do we get the price transparency that consumers would need to shop effectively? So the news about employers shifting that money to workers is remarkably good. The literature is very consistent that in a competitive labor market, what determines overall compensation is the worker's marginal productivity, and if the cost of providing that worker health insurance goes up, their wages come down to compensate very, very quickly. And if the cost of providing them health insurance goes down, their wages go up to compensate, because it's all coming out of the same amount, which is their total compensation, their marginal productivity. And wages make those adjustments with remarkable granularity, so that if the cost of providing health insurance to women of childbearing age goes up, wages come down, but only for women of childbearing age, not for everybody else. And that is one of the reasons why I say that when employers give workers this money as cash, women and older workers and other groups with higher medical expenses are going to get a bigger cash out because the labor market had adjusted their wages downward by more than wages for other workers with lower medical expenses. So the literature is remarkably clear about that. And as for price transparency, that last graph that I showed about how prices were falling when insurers made consumers price conscious and they shopped around and changed their behavior based on price, and that forced producers to reduce their price, engage in price competition. Those studies also found that when the consumers were price sensitive and began demanding price information from producers, the producers gave it to them. Prices all of a sudden became transparent once consumers cared about them. If consumers are spending other people's money, they don't care about prices or transparent prices or whatever. They don't ask for price information, or not enough of them do to change producer behavior. But once a critical mass of consumers do care about price information, prices become transparent as a matter of course. So shifting that $1 trillion from employers to workers, or reforming the Medicare program to give workers cash, that's going to result in price transparency almost instantaneously.
Can I just pick up on that briefly?
Yeah.
So we've attempted to regulate price transparency in healthcare. There have been a series of initiatives, both at the federal and the state levels. They haven't worked out very well because there turn out to be all sorts of ways of dragging your feet and gaming what it is you actually disclose. And to the extent there's not what Michael referred to as a critical mass of patients who are demanding, I need to know the price in order to decide whether I'm actually going to receive the services. If you're a hospital and you view the insurance company as your customer rather than the patient, price transparency initiatives just don't have much priority. But if you look elsewhere in the economy outside of the healthcare system, for some reason, even without regulation requiring transparency, prices are everywhere, right? Car dealers advertise it when their whole grocery stores advertise it. Hell, everybody advertises it. They run sales, which is not something you tend to find in healthcare. And that's because you've got disaggregated purchasing power that are making consumption decisions, which is precisely what we don't have in healthcare.
Next question, well, two questions on long-term care, at least one of them from our friend Stephen Moses. What role does long-term care play in the bigger healthcare issue? And how do you think about the huge need for non-medical long-term services and supports that help with functional needs? Can health savings be reinvested there? Since that's largely a Medicaid question, I'll let you do that first.
Well, and from a visiting fellow at Paragon, Steve Moses, who's done 2 papers for Paragon on long-term care reform.
So that question's a plant. Well done.
Well, he tried to get it in for the first panel. Long-term care is a huge part of the Medicaid program. It's a part of the Medicare program, too. I think half of all Medicaid spending is on seniors and people with disabilities on the program. One of the main focuses of Steve's work for Paragon has been the ease at which people can qualify for the Medicaid program that takes away resources from those who really need the public assistance. It is just it's a falsity that people need to be destitute and spend down in order to qualify for the Medicaid program. There are ways that they artificially impoverish themselves, and there's also a huge number of exempt assets that people can buy, and often these are individuals' children or nieces and nephews that are engaging in these types of creative financial planning in order to qualify their parents or their aunt and uncle for Medicaid to pay their long-term care expenses. So that's a significant problem. And if you don't believe me, you could just Google Medicaid long-term care planning and get a list of tons of elder law attorneys that specialize in this type of work. What it does is, because Medicaid long-term care tends to pay pretty low rates, it has led to pretty poor quality of long-term care services. So nursing homes have historically been pretty low quality. And there needs to be more private financing that goes into long-term care, really. So this is an example of the government really crowding out private financing that should be going into that area.
Yeah, the entire field of elder law is almost completely about Medicaid asset planning.
Do we have any questions from our in-person audience? Robin Hanson and then Dan Perrin if we've got time.
You've been talking a lot about political feasibility, and you've talked about what benefits individuals would get, but do we have actual polls that connect those two, that the things you say people should want, do they actually want, and would they push their politicians to favor?
So you've had some polling done on some aspects of your proposals. I would say when you poll people, they want low taxes and they want lots of government spending. And
On them.
on them. And the people get what they want, right? The reason we have $2 trillion budget deficits is because the politicians have delivered low taxes and large amounts of spending. The biggest spending programs are probably the most popular spending programs. And I don't think we have enough politicians, and probably because it's not in their incentive, to actually be truthful about sort of the basic economics of how low taxes and high spending, what that ultimately is going to mean.
Yeah, the polling I've seen says Social Security is massively popular. Medicaid is not popular. Foreign aid is really unpopular. So I think when you give people money, they like it.
The only poll I really trust is the price system. And I'll believe that Social Security is popular when it's voluntary and people still sign up for it. So, but I'm not sure that anyone has done any of this sort of polling. These ideas are not, have not, a lot of these ideas have not been taken up by policymakers to the extent that they've done polling on them yet. But I think that what does poll well, we do have polling information, good polling information on the popularity of a general rule that Congress should not spend more than it brings in revenue. And that the public does seem to support a balanced budget constraint on Congress, maybe a constitutional amendment. And I think that can help with if Congress were to do that, agree to the general rule that Congress shall balance its budget, even though there would still be resistance or there'd still be efforts by people to push back or keep health program spending at current levels. If Congress had to raise taxes high enough to fund spending at current levels, raise taxes by another $1 trillion per year, we'd have something closer to a price system operating in the political arena. People would then voice their true preferences about the size of government a little better once they had to bear more of the cost of it. And we might get countervailing pressure against the Jan Schakowsky surrounding Chairman Rostenkowski's car. People telling Chairman Rostenkowski, no, you're doing the right thing, cut spending, or make whatever reforms are necessary. And we might then get that sort of, even if polls right now say Social Security is popular, or Medicare spending is popular, or whatever, the polls might change if we attached a price to people's preferences the way a balanced budget amendment would. And I'm not sure that, short of a debt crisis, anything else will get us there. And so my hope is that some enterprising politician will take up the cause of a balanced budget amendment to the Constitution, make that their claim to fame, and then that will change the political dynamics surrounding these issues. Anything else to add, David and Brian?
Didn't you do a poll that looked at whether people supported health reform and then added in a question about it's going to cost this much?
We have done that,
Yeah.
and it does, when you ask what if increase your taxes by this much, it was for the pre-existing conditions provisions in the Affordable Care Act or Obamacare, which supposedly end discrimination against people with pre-existing conditions. That polls at 70 or so % until you start asking about the costs. And if you ask about what if your taxes went up, what if there's a mandate, what if your premiums went up, then some of the support from Republicans and independents fell away. And then if you asked, what if it reduced the quality of the health insurance that you get or your family gets, even Democrats turned against this provision. So this provision that everyone thinks is the most popular part of Obamacare, wildly popular, is actually unpopular if people have to face the price of it.
So I think balanced budget amendment, Congress came within one vote of passing it with the 2/3 majority in both houses in the mid-1990s. It would have then had to go to the states. I think it is the growth of the federal budget. It is completely unrealistic to think that we could have a balanced budget amendment now. I think the better way to think about it is just capping debt as 100% of GDP. And if we could have Congress have some type of mechanism there that doesn't let debt go more than 100% of GDP, that could be a realistic forcing mechanism.
Okay. And with that, we are over time, and I apologize we couldn't get to all of your questions, but I want to thank you all for coming and thank our panelists on this panel and our previous panel for their participation.
Thank you.
We're going to be archiving this event on the CATO website, hopefully posting all of the slides from all of our speakers and links to all the papers we cited. And those of you who are here in person are welcome to join us in the conference center for lunch. Thank you.